Respected esteemed faculty, delegates, and friends, a very good evening and pranam. We at Department of Endocrine Surgery, King George Medical University, Lucknow, along with Indian Anti-Cancer Trust, Delhi, are organizing the first KGMU Breast Update 2021 from today. It is a 3-day virtual conference on various aspects of the breast cancers. I welcome you all on behalf of my co-organizing chairman, Dr. Vaishali, organizing secretary, Dr. Kullanjan, and on behalf of my university. We all know that breast cancer is the most common cancer in our country, and with enhanced awareness and enhanced use of chemotherapy as a new adjuvant, more and more patients are eligible for breast cancer therapy. And oncoplasty is very important part of this breast cancer therapy. Our conference is planned to discuss the various aspects of the breast cancer, which includes imaging, pathology, treatment planning, and this will be discussed on the day 1. Day 2 will be basically devoted to the various techniques of the oncoplasty techniques, how I do it sessions, and on third day we'll be discussing various special issues in the breast cancers like ICJ use, pregnancy associated cancer, or LABC. On this occasion, I thank my university administration, Vice Chancellor, Lieutenant Colonel Bipin Puri sir, Pro Vice Chancellor, Professor Vineet Sharma, staff of the department, and my sincere thanks to all the faculty, co-organizing chairman, Dr. Vaishali, Dr. Kullanjan, and event organizer, Nice Ideas. With these words, now I invite the chairperson for today's first day meeting, Dr. Ashwin. Before that, I hand over to the things to the Ashwin. I will request all the faculties to finish their talk in 15 minutes, or maybe before that, so that we can have at least one question answer session. And I will request all the faculties to be connected to the sessions, because we'll be getting the questions from the delegates, because it's a different platform, Zoom platform, in the chat box, so that they can answer. Dr. Ashwin is Honorary Secretary of the Association of Breast Surgeons of India. He is Consultant Surgical and Robotic Surgeon at High-Peak Super Specialty Manipal Comprehensive Cancer Center, Bangalore. He is European Board Certified Surgical Oncologist. He has to his name various awards and international travel grants, including European Society of Surgical Oncology and ESMO. He has received other various international fellowships from top universities, Pittsburgh, Mayo Clinic, Trent Hospital, UK. I hand over things to the Dr. Ashwin. Dr. Ashwin.
Thank you, Dr. Anand. First, I'd like to congratulate you and your team for an excellent scientific program. And thank you for partnering with ABSI and for having a 3-day program is a great achievement. And I'm sure lots of people will be attending and they'll get a lot of benefit out of this. So first, we'll go on to the first talk. The first talk will be given by Dr. Mala Mathur Sharma Colonel, who is a clinical professor and Department of General Surgery in Breast Diseases Division at Amrita Institute of Medical Sciences. She's a graduate and a postgraduate from the prestigious AFMC. She has special interest in various publications in breast, thoracic, and GI surgery, and also been trained in breast oncoplasty. So I invite her to give a talk on TNM staging of breast cancer. Is it keeping up with good times? Over to you, Dr.
Good evening, everybody. Let me come straight away to the point and start my presentation. Don't want to waste any time. So let's speak about the TNM staging. Everybody can see my screen now?
No, ma'am, not yet. Please share your screen.
Okay, fine. Now is it shared?
Yes, ma'am. Put it on a slideshow mode.
Yeah. Is it okay now?
Yes.
So let me come to the point. I don't want to waste any more time talking all these things. So let's today we are going to talk about how the TNM staging of the breast cancer is keeping up with times. So basically, let's talk about AJCC 7th edition. This was being followed till December 2017. This was an anatomical staging, and the quantitative assessment of the tumor was the one which was actually deciding how much, what would the stage be. So we were measuring the tumor size and the nodal burden. But in this staging, it was not taking into account the tumor's inherent ability to recur. And the fact was not appreciated that the tumor is right from its inception has a particular properties in biology, which is what is making the tumor more aggressive or less aggressive. So it was just quantitative assessment of the tumor, and we were staging as per that. So even now we are using anatomical staging in many places because biomarkers are not available. Coming to AJCC 8th edition, what has changed? It has been felt that we need a more biomarker driven prognostic staging of the breast cancer. Now what has happened, we have added on IHC markers, we have added tumor grid and proliferation indexes, and this has changed the way we look at staging. And this particular staging has been complemented to anatomical staging, which has impacted the management practices. And it is predictive synergy. We are able to predict tumor biology and tumor behavior. So this particular staging, AJCC 8th edition, is in sync with the tumor biology, and it has practical implications on decision making. So that is the difference between AJCC 8th and AJCC 7th edition. So now coming to IHC markers, we were doing IHC markers before also, we've been doing for a long time, but we were not taking their prognostic value into consideration because their impact on survival was not available to us, and we didn't have any genomic studies. But what was happening was that because of they were not being taken into account, we were doing a lot of over treatment with chemotherapy, and there were so many side effects which were outweighing the benefits which a patient would get through chemotherapy. This particular staging helps us to allow the patients which are having favorable prognosis to forego chemotherapy altogether, because we are now, it is a more management focused staging. Coming to the anatomical, this AJCC has got 3 tables. It's an anatomical table, it has a clinical prognostic table, and it has a pathological prognostic table. So there are 3 different tables, but I am today going to only concentrate on pathological because there is a bit of a change in between clinical and pathological tables. So I don't want to go into that. It's too much of a confusion and the time doesn't permit that. So let's stick to the pathological prognostic table. Now, what are the main changes which is occurred in AJCC 8th edition? The primary tumor, LCIS, the lobular carcinoma situ, is no more cancer. It's a benign entity. Tumor size, tumor T1 microscopic is 1 millimeter. If it is even 1.1 millimeter, it does not get rounded to 1 millimeter. It goes up to 2 millimeter. So only 1 millimeter and less is considered T1 MI. Everything above that is 2 millimeters. Small microscopic satellite nodules do not add up to T size, and then there's synchronous tumors, only the largest tumor is counted, and only macroscopic visible skin nodules away from the primary tumor add on to T4B. Microscopic nodules seen are not adding on to T4B. These are the major gross changes which have been introduced. Coming to other changes, biomarkers like ER, PR and Herceptin status have been added on to this, but we do not do multigenal panels. They are not recommended, and they may be used as stage modifier in appropriated cases, but they are not routinely recommended and they are not available in most of the countries. Coming to IHC4 score, IHC4 score is the most important score which has been taken into TNM staging. What is this? This is a prognostic model, semi-quantitative assessment of IHC markers which are ER, PR, Herceptin and Ki67. These are cost effective, easily available, and their prognostic assessment has well correlated with 21 gene oncotype DX prognostication. So this information can be translated, though we do not have OncoDX, we can translate that information into these 4 parameters and we can accordingly correlate. Now coming to these IHC4, how do they help in molecular classification? They help us to decide 4 types of tumor subtypes. One is luminar A, which is ER/PR positive, Herceptin negative, and Ki is low. Ki we keep cutoff is 14%. Luminal B is ER/PR positive, Herceptin positive or negative, but Ki is high. Herceptin positive tumors are the enriched tumors. These are ER/PR negative, only Herceptin positive. And then we have triple negative tumor with high Ki. So this is the 4 basic classifications which have been propagated. Now this is a small chart which I have taken down, and I would like to explain how these things work out. You see, luminal A light are ER/PR positive and negative. They have high luminal ceratokine proliferation, and they are low grade tumors with high ER expression. They are the commonest, 60 to 70%. Now, as we move from this towards the left side, we find that 10 to 20% luminal B, Herceptin 2 plus, 2 minus, Herceptin unreached, and then triple negative. So proliferation index and high grade increases towards the left. These are more basal type tumors, and these are low grade tumors which are luminal A like. Now coming to other scores, we have integrated G1, 2 and G3 as the 3 types of grading systems into this. So they are integrated into this. Coming to anatomical staging. Anatomical staging, as we can see, this is the common anatomical staging as available in AJCC 7 and also incorporated 8. Now we are going to correlate this to the other AJCC staging which we are going to see now. So what has happened is AJCC 8 is the prognostic staging. Now I can show you here. This is a T1 staging. T1, N1, T0, N1. These are the thing, and this is the latest AJCC's 8th edition. This we can see all the triple negative tumor are only correlating to stage 1B. Rest all have been downstage to stage 1A. So the only one stage, 2 stage B are those are the triple negative tumors. I'll just get my pointer. Yeah. So only triple negative tumors are the ones which are stage B. Everything else is downstage to stage 1. Coming to the next one. This is stage 2A. T1, N1, T2, N0. These are, as you can see, all the triple positive tumors are only stage 1A. They have been downstage to stage 1A. Triple positive, grade 1, grade 2 are all become 1A. And grade 3 triple positive has become also 1A. Only triple negative have become 2A. So 2A, only triple negative are 2A. All the ERPR positive tumors have all become 1A. Only G3 triple positive is 1B. So we are downstage the tumors if they are ERPR positive. Coming to stage 2B, which is T2N1 and T3N0. Same thing again. As we can see, all ERPR positive tumors are 1A. Actually, anatomical staging is 2B, but they will be, as far as management goes, they will be treated as 1A. Triple positive grade 2 will be 1B, and triple positive grade 3 also is 1B. However, grade 3 triple negative have become 3A. So this is one category in stage B which has got upstage to stage 3A because of the inherent biology of triple negativity. Rest all ERPR positives, as we see, have been downstage from stage B 2B to stage 1B and 1A if they are less grade. Coming to stage 3A, again stage 3, as you can see, T2N1, T3N1, T3N2. All these are stage 3 tumors, stage 3A. As we can see, all triple positive tumors are 1B. A triple positive tumor grade 1, even if it is N2, will be treated as stage 1B. Similarly, grade 2 is 1B. And grade 3 is 2A. So all the tumors have been downgraded to stage 1B and 2A if they are good biology tumor, if they are triple positive. However, if you can see, even triple Herceptin negative positive is 1B. So ER positivity, as we can see in this table, has been very important. All those circled in green are the ones which have been downstage, and those circled in red are the ones which have been upstage. So we see triple negative tumor grade 2 and grade 3 have become 3C and 3B when they were anatomically graded as 3A. So 3 has got upgraded to 3B and 3C when they are triple negative, and it has got downstage to 1B when they are ERPR positive and triple positive. Coming to stage 3B and 3C. Now in this, mostly, now there is not much change. I have underlined in this green, these are the only 3 tumors which are good biology tumors, triple positive. They have been downstage from stage 3B and 3C to stage 3A. Otherwise, most of the other tumors are generally following the same staging. Coming to oncotype DX. Now oncotype DX has also been incorporated, and there has been a table which has been added in AJCC. This particularly, actually oncotype DX, I'll be talking a little bit about it. This is when the score is less than 11. These are good biology tumor. So all ERPR positive and Herceptin negative tumor which are node negative. See this N0. All T1, T2, N0 tumors of any grade, if they are Herceptin negative and ER positive, they will always be treated as stage 1A. Prognostically and pathologically, they will be treated. So if you have a 5 centimeter or 4.5 centimeter tumor with N0 status, grade 3 also, if it is ER positive and oncotype's DX score is less than 11, you can safely take that patient as 1A. It will be a better biology tumor and patient has survival benefit. Now, I have made a summary of all the changes, the major changes. So as you can see, T1 and N1 and N0 tumors, triple negative have all been upgraded from 1A to 1B. Triple positive have been upgraded from 1B to 1A. So all this is the great change. Coming to again, let me go down. These are T3 and stage 3 tumors. Triple positive stage 3 tumors, 3A have been down stage to 1B, and triple negative have been up stage to 3C. So this table generally gives us an idea. Similarly, these are stage 2 tumors. All triple positive from 2A have become 1A, and all triple negatives from 2B have become 3A. So the triple negativity upstages the tumor, and triple positivity or ER/PR positivity, more important, downstages the tumor. Coming to prognostic staging. Prognostic staging has been predictive markers, prognostic markers. What are they predicting? They are predicting chemosensitivity, higher response to NACT, and which are the patients which will benefit from adjuvant chemotherapy. This is what we are looking at. And this has also got nuclear grade, tumor size, nodal status. Everything is predictive, prognostic. They have got two types of scores, a recurrence score and a recurrence risk. Now coming to this is a very nice diagram which I'll show you. These are all the prognostic markers. All these genetic markers, IHC markers, and tumor age, tumor size, nodal status, LVM. Out of this, only these markers are the ones which predict response to therapy. So when you are making a management decision on therapeutic response, we need only these markers, grade and multigene. But rest, everything else is a prognostic marker. This is a beautiful diagram which predicts what we are trying to say. Coming to multigene prognostic assays, we have three types of assays. First generation, which are the ones which have been there for a long time, like Oncotype DX, MammaPrint, and GCI. They are more accurate in predicting recurrence within 5 years, but not in the later years. Second generation tests are the ones which have come up now, Prosigna, EndoPredict, and BCI. They are better prognostic in late recurrences, but they are not so good in early relapses. And then we have a huge panel of many tests coming up, which are basically going to have some extended predictive models. We don't know what models will come, but we are they are all in the studies. So coming to Oncotype DX, let me talk a little bit about Oncotype DX. It's a prognostic assay, and it is a 21 gene panel. This is the only thing which has got AJCC level 1 evidence. So AJCC level 1 evidence is there, and that's why it has been incorporated AJCC staging. It has got 16 plus 5 genes, and it has a continuous score of 0 to 100, and it has been validated by NSABP trial B14 and B20. The score is categorized into low risk, intermediate risk, and high risk, less than 18, 18 to 30, and more than 31. A low recurrence score suggests there is a 2% distant recurrence in 10 years. So that is a subset of patients who will not benefit from chemotherapy. Now, many other trials are going on. Taylor X, Soft X, and all these trials which are looking at various other roles and roles of in endocrine therapy. Coming back to drawback of oncotypes, the drawback of Oncotype DX is that it does not provide prognostic information in node positive patients. It's only for node negative, and it does not predict late recurrences. However, there are some other trials going on, like this RX Ponter trial. They are all looking into these other aspects of these things. Now, I'll just briefly skim through some other things like MammaPrint, 70 gene signature, level evidence 2 only. It is more good at predicting long-term recurrences. These are the trials which are going on about MammaPrint. Coming to GCI, these are all first generation. GCI, MammaPrint, and this. This is again 97 gene measure. It has 2 scores, GG1 and GG3. And it is more into early recurrences, so it impacts early decision making. These are the great second generation, the EndoPredict. It's again a multi-gene test. It predicts distant recurrences, and especially on patients who are on adjuvant endocrine therapy, who can avoid a 10-year of endocrine therapy. This is the main thing in EndoPredict. Level of evidence, AJCC 2. Prosigna is a PAM50 gene signature. It classifies tumor into 4 types like luminal A, B, Herceptin, and basal-like. It is measured in risk of recurrence ROR score, again from 0 to 100, with low, intermediate, and high scores, and AJCC level 2. Some trials, these are the trials which are going on about Prosigna. Coming to breast cancer index, again it is a second generation genomic study. It has more of estrogen signaling pathway, so it is measuring expression of these 2 genes, and it identifies a group of ER positive patients who are at risk for late recurrences. and those are the people who are likely to be given 10 years letrozole. Again, AJCC level 2 evidence not yet completely incorporated. IHC force care I already spoken to you about. AJCC level 2 evidence, it correlates very well with oncotype DX. That is why we are using this in our scoring. Coming to OncoMass TR, these are all new tests which have come up and they are not yet validated by any of the major studies. Just for information, RT-qPCR test, it gives a late distant recurrence prognostic information. Cure Best 97 GC breast assay, validated for performance for more less than 5 years, and 95 gene assay, again 95 genes. So many of them are coming up now. There are no validations, trials are going on. So let me conclude my talk by a simple thing. Why do we need this thing? Clinical parameters is still very important. We must remember that clinical parameters in staging is very important to determine prognosis. Genomic assays should only be used in conjunction with these. Prognostic and predictive markers are not to be used without the basic tumor markers for management planning. So we cannot give away ERPR and just do a oncotype DX and decide what kind of treatment we're going to give. Those 4 markers are absolutely prerequisite. Multi-gene panel should not be incorporated. Only for certain selected breast cancer patients, we can do oncotype DX with some multi-gene, but they are not to be done in the part of a staging system. And more than one multi-gene assay at a time for one patient is not recommended. So these are the 4 basic take-home messages. These are the references. Thanks to these things, and I would like to thank my medical oncology colleague who has helped me understand this confusing AJCC 8. Thank you very much.
Thank you, Dr. Mala. It was a great presentation. I know it was a big topic, and you had to put that in 15 minutes. It was an excellent presentation. Thank you for telling us that you need to tailor treatment, and we depend so much on pathology, especially the IHCs and the genomic testing. So you have told us that tailoring therapy and not over treating the early breast cancer has been a boon, and a lot of people, women especially, are thankful that we skipped chemotherapy unnecessary. I mean, instead of giving unnecessary chemotherapy. Thanks a lot. Is there any question for Dr. Mala? So shall we go on to the next topic? Thank you, Dr. Mala, for the great presentation. So I invite Dr. Smriti Hari, who is a professor at the Department of Radiology at AIIMS, New Delhi. She's an editorial member and also has been editor for several international reputed journals. Also member of many international affiliation. I would like to call Dr. Smriti to give a talk on interventional radiologist, a key figure in breast cancer. Dr. Smriti.
Thank you, Dr. Ashwin, for the kind introduction, and I would like to thank Dr. Anand Mishra to give me let me participate in this conference, which is mainly for surgeons. So I would now share my screen. So I will like to talk about the various steps in the diagnosis and treatment of breast cancer, where interventional radiologists can help the surgeon in reaching a good outcome. I will not talk much about the details of the procedures, as much about when they should be done and what are the indications and how they are helpful. So I'm going to cover procedures. One are basic procedures like our dal chawar, which almost every hospital has, and they can be enough to help the surgeon with 90% of the patients. And then of course there are some savories, our cakes and pastries, which you have, it is better, it is good, welcome, but if you don't have, you can do with your dal chawal as well. So these little advanced procedures would be stereotactic biopsy, vacuum assisted biopsy, and MR guided biopsy. So let's move to the slide telling us what a surgeon would want to know when there is suspected breast cancer. So these are the points that a surgeon would like to know, and let me show you how interventional breast radiology can help at each step. So is there cancer in the breast? So you can see these two very similar looking lesions on ultrasound, and one of them turns out to be a fibroadenoma and the other one turns out to be a triple negative cancer. So this brings home the point that there is a significant overlap in the imaging features of benign and malignant lesions, and therefore you need image guided breast biopsy whenever the suspicion of malignancy is more than 2%, which puts the lesion, the abnormality, in the category of more than BIRADS 3. So it is beyond doubt that core biopsy is better than FNAC, because you don't get insufficient samples and there is a histological tissue diagnosis, hormone receptor status can be known. So we should rather abandon FNACs and completely switch over to core biopsies. Core biopsy should always be done with a 14 gauge needle and always a long throw, 2 centimeter sample notch is used irrespective of the lesion size, because for the pathologist, the more the tissue, the better it is to give a definitive diagnosis. Number of cores is very important, and as you can see, the accuracy goes up with the number with good samples which are sinking. About 3 cores are enough. So I had this interesting thought that, why should we do image guided biopsy of the palpable breast masses? So we undertook a randomized study, the only one of its kind actually in the literature, where we took 72 patients and randomized them into 2 groups. One group underwent palpation guided biopsies in the minor OT, as was the practice, and the other half came to the radiology department. So we were quite surprised ourselves at the results that there was a big chunk of patients in the palpation guided biopsy group who had insufficient, inconclusive samples and who were advised rebiopsy. The reason being that when you are palpating and doing a biopsy, you cannot differentiate the induration and the desmoplastic reaction from the actual tumor. You cannot make out whether you are taking biopsy from a necrotic area or a more solid and viable area. So after that, the practice changed in my institution, and we are doing ultrasound guided biopsies for all patients, even when the lesions are palpable. This is an example from that study where this mucinous cancer was again and again diagnosed as inflammation on palpation guided biopsy, was only diagnosed on ultrasound guided biopsy. So this is the simple ultrasound guided biopsy where you can visualize where the needle is going and you can take your sample under direct visualization. But one caveat here is there is no biopsy technique which can claim to have a zero sampling error. So the concordance between the histology and imaging findings should always be made so that we can avoid missing any cancer because of sampling error. And that means that if you think that the imaging was highly suspicious and the diagnosis came as benign, you must repeat that biopsy, or surgical excision should be advised if there was a high risk lesion on the biopsy. Secondly, the surgeon would like to know whether the axillary nodes are involved, for which ultrasound is very sensitive to detect suspicious lymph nodes, provided the radiologist knows where the surgeon's axilla is. Often I find that the radiologists are not aware of where to look for level 1 nodes, and they would rather put their probe high up in the axilla. So all the radiologists need to know where to look for level 1 nodes. And then we have a high concordance between the clinical findings and the ultrasound findings. So sentinel lymph node biopsy can be avoided in that subset of patients where the axillary lymph node is found to be suspicious and then is proven on biopsy or FNAC to be malignant. So these patients can straight away go for axillary dissection. So there are these ultrasound features of metastatic nodes, out of which most specific are the rounding of lymph nodes or loss of fatty hilum. cortical thickening, focal or diffuse, can occur in the reactive group as well. That is why the need for biopsy, because sensitivity of ultrasound is high, but the specificity without biopsy is not so high. So we spoke about the algorithm. And for surgery, we are moving more and more towards less surgery, and for which correct patient selection is very important. And for this, again, a radiologist will come in very useful. Clip deployment in patients undergoing NACT should be performed, because the purpose of NACT most of the times is to make an inoperable cancer operable, or an operable cancer to be shifted to a conservative approach. But most important is that before it vanishes, you should put a clip. So a clip will help the surgeon to mark that site on the day of the surgery with hook wire, and then the conservative surgery can be done very well. So clip deployment, unfortunately, we never had the company made clips in our country. So we used to devise our own in sometimes with coils, sometimes whatever way. And we have been deploying clips for the last 18 years in the institute. Then we improved upon our do-it-ourselves clip, and with IIT devised a low-cost titanium clip, so which is coming in very handy. And afterwards, this clip needs to be localized with wire. So either the clip or a non-palpable screening detected cancer, the surgeon will be able to operate with the help of interventional radiologist, who is going to localize the small cancer with wire localization. So this wire localization can be done under mammography, ultrasound, or MRI guidance, in whichever modality the lesion is best seen. So for this is the hardware that you require. This is a J-shaped hook wire. This is another hook wire, and these are placed through these open compression plates on mammography when we are doing a mammography guided hook wire insertion. This is the procedure. I'm skipping the details of the procedures. So this is how the surgery is done with the help of the wire. The important thing is for the surgeons to know that the entry site of the wire is always a little away from the tumor. We cannot directly put a wire in the anterior-posterior direction. We have to go from the side, be it in mammography or in ultrasound. So the surgeon should insist that the radiologist marks on the skin the site of the tumor with the help of ultrasound, and also tells you the depth of the hook from the skin, so that the incision can be made right above the tumor, and you don't have to make a large dissection tract along the wire. So afterwards, when the wire guided excision has been done, the surgery is not over until a specimen radiograph is done, and which shows that the entire wire along with the lesion is removed. So only when this result is communicated to the waiting surgeon in the OT is the operation closed. So we can do this wire guided localization even on ultrasound, and this is what I meant, that the wire is going to enter from a distance from the tumor. So we have marked the tumor on the skin and measured the distance of the tumor. So this is the tiny tumor, and then after the surgery we have done a specimen radiograph to confirm that the wire and the tumor is indeed out. Because of the hassles of wire, the fact that it can break during surgery, or it can move, and plus it has to be scheduled on the day of the surgery, newer methods of localization have come into vogue in the developed world, and where you use a radioactive seed, which is iodine 125 seed for localization, or you could use a magnetic seed, and these can then be picked up by gamma probe or any other suitable probe.
Dr. Smriti, 2 more minutes left.
Yeah, I'm almost done.
Thanks.
So when the lesions are larger, hook wire bracketing can be done. That means that you deploy 2 or more hook wires to help the surgeon excise a larger area of tissue. And especially with the oncoplastic techniques, now surgeons are able to give good results even with the excising larger tumors. So lastly, at the time of surgery also, an interventional radiologist can come in handy by doing an ultrasound intraoperatively, so that the excision is accurate, especially in lesions which are vaguely palpable, not palpable. So this could be an option. If you don't want to do hook wire, you could do an intraoperative ultrasound guided local excision. So this is how you decide where the incision is going to be. This is an ultrasound being done in the operation theater. So the skin is being marked where the tumor is. And then even during the surgery, you can apply your probe, which has been put into a sterile camera sleeve multiple times to decide upon the excision planes, and you can see from various angles, ensuring the maintenance of resection margins. And later on, the specimen can also be seen for seeing that the entire mass has been removed. So now I'm coming to the little higher interventional procedures. One is vacuum assisted biopsy, where you can take more tissue. So
Dr.
this
Smriti, the time is up. Can we come to the conclusion side, please?
Fine.
Thank you.
So stereotactic biopsy can be done. I'm just going to show you of course, we've gone to the clip deployment as well. So with that, I'd like to end my talk. If I have any questions.
Right. Thank you, Dr. Smriti. So it was an excellent talk. With the screening mammograms and with the awareness, now more and more women are getting the screening done with MRI, and we're seeing more and more people with having non-palpable lesions. But the way of presentation you showed us how meticulous you were about marking the non-palpable lesion, wire localization, and also you insist on having a post-surgical mammogram. I can tell you, it's like you have a great team, and kudos to you. And I'm sure AIMS doctors are very lucky to have you there, because I can tell you how much coordination it takes in OT to tell us, because the wire is so sensitive that we can't even move it 1 millimeter, but because you'll be ending up away from the lesion. So it was very interesting to know that you follow every step to the T. Thank you.
Another good technique that the surgeons follow in our place is that once the patient reaches the OT, they cover the wire with a hollow needle. So that gives it more stability. You can use any lumbar puncture needle or any needle and thread it over the wire. So
right.
You get stability of the wire, and there's no risk of transaction.
Right. Oh, that's a great trick. Thank you. So Dr. Dev is very lucky. Thank you, Dr. Smriti.
Thank you.
Right. So we'll be going to the next talk. It will be given by Dr. Pragnya Chigurapati, who is a consultant breast oncologist and oncosurgeon from AIG Hospital. So she's a member of the prestigious Royal College of Surgeons from Edinburgh. And also she has great extensive experience in oncoplastic technique, and she's a breast oncoplastic fellowship from the Royal Stoke University, where even I did my observership at Stoke-on-Trent. So I invite Dr. Pragnya to please give a talk on intraoperative margin assessment. Over to you, Dr. Pragnya.
Thank you, Dr. Ashwin. Thank you for having me here. I'm just going to share my screen. I hope you can see this.
Yes, ma'am.
Yes. Okay, great. All right. Hi, everyone. I'm Dr. Pragnya Chigurapati Naira. I'm a consultant breast oncologist and oncoplastic surgeon, and I'm working in Hyderabad. My topic for today is intraoperative assessment of margins in breast conservation surgery. I'm going to try and keep this as short as possible, but I think I'm going to overrun my time. So to begin, numerous studies have demonstrated equivalent survival outcomes for BCT and mastectomy. The goal of BCT is to excise the tumor with negative margins while providing good cosmetic outcomes. As we all know, when there are positive margins, it will lead to an increased local recurrence, twice those of patients with negative margins. The rates of re-excision reported in literature range from less than 10% to greater than 50%, not explained by the characteristics of either patients or their disease. And this leads to, with increased re-excisions, it means more return to theater, there's additional anesthesia, there's increased healthcare costs, increased conversion to bilateral mastectomies or unilateral mastectomies. And in the Indian scenario, re-excisions, that is a second surgery, is a big no-no. The NCCN guidelines currently say that for any invasive carcinoma, the margins should be no incon tumor. And if there is a positive margin and if re-excision is feasible to allow a no incon tumor, you can re-excise. But if there are repeated positive margins, you should go ahead for a mastectomy. For a DCIS, for patients with pure DCIS treated by BCS and whole breast radiation, a margin of 2 millimeters is recommended. And for DCIS with microinvasion, the optimal margin is still equal to more than 2 millimeters. But there continues to be a variation in the margin status amongst a few surgeons in different countries. The inability to obtain clear margins at the time of breast conservation surgery for invasive carcinoma or DCIS, it remains a significant problem even till today. Intraoperative assessment of margin status might minimize the need for second procedures. However, most of the described procedures, which I will come to, have limitations in our country, resource constraints and financial aspects are a huge issue. Due to the chance of needing a re-excision, many women opt for a mastectomy. Although eliminating re-excisions for patients undergoing a breast conservation surgery completely is not feasible, there are a few intraoperative techniques which can help reduce the need for re-excisions. However, you should note that this effort of reducing re-excisions of second surgeries must begin from the time of diagnosis. That is high-quality mammograms, supplemental imaging, if necessary, that's MRI, ultrasound, etc., minimally invasive diagnostic procedures, and multidisciplinary tumor meetings are extremely important to make the right decision. So the techniques involve preoperative localization as well as intraoperative localization. It doesn't necessarily have to be only intraoperative. Preoperative localization, I'm just going to get to that quickly. Stereotactic needle localization. Needle localization can be done either via ultrasound guidance or stereotactic, as mentioned in the previous talk as well. So the breast is placed in compression paddles with an alphanumeric grid, targeting the area of concern with the shortest skin to lesion distance. Two images are taken in two views, CC and MLO. The wire is deployed. Post-placement images are taken to confirm. And superficially, there is a skin marker that is placed to guide the surgeon. And post-operatively, a specimen mammogram is done to make sure that we've actually taken out the lesion. Ultrasound-guided needle localization is that the patient is in supine or lateral decubitus position, and the lesion is visualized under ultrasound guidance, following which the wire is placed, as you can see in picture B. And post-procedure mammogram is performed or an ultrasound to confirm the position of the needle. But the important considerations of needle localization are that it's obviously a same-day placement, higher chances of displacement of the wire. It requires a great deal of coordination between the surgeon and radiologist, which is not always possible. It affects the incision placement, and which may in turn affect the cosmesis. And this might lead to higher re-excision rates if the entire lesion is not taken out. And it can be expensive in certain countries, definitely in our country. And of course, resource constraints are a major issue. The other technique for preoperative localization, which most of our centers currently do, are ultrasound marking, which is marked on the day of surgery, and the distance from the skin to the lesion is noted in one from top to bottom, and the other dimensions are also taken into account if required for proper excision. What we used to do is a core biopsy scar used to guide us to the lesion. In case of both a palpable lesion and a non-palpable lesion, but again, non-palpable lesion, the chance of re-excision might be slightly higher. And the other limitations of a core biopsy scar guiding us to the lesion are that sometimes the biopsy scar might fade away, and if there's a hematoma, it distorts the tumor in cases of upfront surgery, and it is challenging in dark-skinned individuals. This is done in only those cases when we can't place a clip because it's too expensive. Coming to intraoperative ultrasound, most of us do this. On the table, the lesion is identified with an ultrasound and skin markings are made on either end of the probe and connected. Now the probe is turned to 90 degrees and then again, both the ends of the probe are marked. So the entire dimension of the lesion is given to us. For lesions not visible on an ultrasound, although I have not done this, an iatrogenic hematoma may allow us to use an intraoperative ultrasound, which guides us to the dimensions of the tumor, or sometimes a dissolvable marker might be placed. The advantages are that it is easily available and there's short learning curve. The limitations, however, are technical skills are required. It is operator dependent and it requires an in-house radiologist unless the surgeon himself is trained in ultrasound. The following studies which I mentioned here show that for both palpable, non-palpable, and DCIS, there are a few positive margins for intraoperative ultrasound compared to needle localization. And in a multi-center randomized control trial showed that intraoperative ultrasound guided surgery significantly lowers the proportion of tumor-involved resection margins compared with the palpation-guided surgery, with most of the surgeons still follow, thus reducing the re-excision rates, mastectomy, and boost radiation. So these are the intraoperative ultrasound. This is how it's done. It's marked on the table and sometimes intraoperatively during the resection of the tumor. And the final specimens. The margins are measured, and if re-excision is required, we can go ahead on table itself. Now, coming to radio-guided surgery, which was already mentioned in the previous talk, it consists of either radioactive seed localization or radiocolloid injection into the lesion and gamma probe-guided excision. That's called a roll technique. RSL, which is a radioactive seed localization, was first described in 2001. It is basically the titanium capsule which contains this radioactive iodine 125, and an internal gold marker is inserted into the breast lesion, followed by excision, which is guided by a gamma probe. And studies have shown that re-excision rates are much lower with a radioactive seed localization compared to wire localization and roll techniques for both palpable and non-palpable tumors. So this is the capsule. This is the needle through which we insert the capsule into the breast, a post insertion image. This is the gamma probe being used in theater, and this is a specimen mammogram. Radio-guided occult lesion localization. It involves the injection of technetium-99 nanocolloid intratumorally, confirmed on lymphoscintigraphy and excised using a gamma probe or a gamma camera. So this is a gamma probe being used in theater. This is a portable gamma camera, again, which is being used in theater. Now, when you inject this, the only disadvantage is that there's diffuse uptake, diffuse localization rather than a focal localization, which we see with an RSL. These are the images that you see with the injection of a technetium dye. This is the tumor, and we can safely say that this is margin negative, whereas here, but unfortunately, the margin is quite close. They had to re-excise it. The studies by Ninikowski shows reoperation rates and local recurrence-free survival rates were comparable for roll and RSL technique in case of impalpable tumors. And the Thiessen et al., this is the next largest study, shows that RSL showed a higher tumor-free margin rate compared to roll and fewer re-excision rates compared to roll. So obviously RSL is accepted, but there are limitations and advantages to both. RSL, it's more flexible in scheduling because we can insert the capsule a few days earlier because of the half-life, precise tissue removal because of focal localization, lesser excision, allows cosmetic incisions, unlike wire localized excisions. There's lesser workload on the radiologist because you can insert it a few days earlier. And there's no Compton effect. That is, it does not interfere with the technetium dye, the radiocolloid dye that's injected for a sentinel node biopsy. And the limitations, however, are that it's radioactive, so it has to be properly disposed, and it's expensive and requires a proper setup. Whereas for roll technique, the advantages are that compared to a wire localization, there are lower re-excision rates, but the short half-life of technetium shows that it has to be injected the day before, the night before, or in the morning of the surgery. And because of the diffused localization, you might excise a larger amount of tissue, which may affect the cosmetic outcome. Now, coming to the pathological assessment of it, this gross assessment, India Inc. is used to define all the 6 margins, and the specimen is then serially sectioned. Along with that, we also use the marking technique with sutures, which show short superior and long lateral. Studies show that with gross margin evaluation with proper intraoperative re-excision, there are studies which showed that the re-excision rates decreased from 21.4% to 9%. And this is the study done by Fleming and colleagues. And other studies show that there is a decrease in re-excision rates as well. But there are other techniques which prove to be more beneficial. Advantages are that it can be performed by both the pathologist and the surgeon. It has a very short learning curve. Whereas limitations are it's not validated, and second surgery leads to increased re-excision rates, which leads to patient distress, potential morbidity, cosmesis, and cosmesis is affected, and additional financial burden for a second surgery. So we went on to a specimen radiology, which is basically the excised specimen is oriented by the surgeon and delivered to the radiologist, followed by the pathologist, where the margins are assessed. This can be done for both palpable, non-palpable tumors, as well as microcalcification. The standard of care involves using X-ray projection to localize the center of the visible tumor and verify that the specimen contains the tumor. And if any margins are close by, we will be notified and we can go ahead and re-excise. So there is a meta-analysis by Odisio et al. Which suggested that specimen radiography is likely inferior to intraoperative pathological assessment in achieving adequate margins of excision. There's another series for DCI specifically that reported the use of this technique eliminated the need for second surgery in around 28.4% of the patients. So, and then another series that shows that both invasive and in situ carcinoma, there was a decrease re-excision rates by 24.2%. So currently the guidelines say that the addition of a specimen radiography for the express purpose of improving the rates of inadequate margins of excision cannot currently be recommended based on the available evidence. But it can be used for microcalcifications to make sure that we at least have a rough idea in those centers without intrapathology. Now, intraoperative digital specimen radiography, it's also known as faxitron imaging. In the operation room, the specimen is placed inside this device and a mammogram is taken.
Dr. Pragna, you have 2 minutes. You have 2 minutes left.
I'm going to run through. Studies showed no significant reduction in the operative times, but did reduce the incidence of positive margins. This is intraoperative digital mammography. Frozen section, as we all know, so the specimen is marked and embedded in optimal cutting temperature. Sections are made and frozen. They're leveled and frozen in a cryostat. This is used for leveling, and at around 25 degrees, they cut into slices and fixed into ethanol. H&E staining, slides are prepared, and it's finally studied. But however, even though this is proven to be quite beneficial, it's not many centers perform a frozen section analysis. I'm not going to go through the studies. The other is imprint cytology. It's basically live tissue samples are rubbed onto a glass slide, and the attached slides are fixed with ethanol, based on the idea that malignant cells will adhere to the slides, whereas adipose cells will not. And the slides are examined. The one study is a meta-analysis which showed that both frozen section and intraoperative imprint cytology, if available, showed the best results. Cavity shave is predominantly used in UK currently. All the cavity shave margins of all the 6 sites are taken and sent for frozen section or routine histopathology, and based on that, we go ahead and re-excise if required. This should be taken up as per recommendations in centers who have a re-excision rate of higher than 25%. Just a quick note on the other devices that are being used currently and studied. Savvy Scout, which is basically based on infrared activated electromagnetic wave reflector. This is inserted into the breast, and we have a probe that tries to detect the presence of this and using infrared rays, and it appears on this console. Of course, I'm not going to go through this because of the current time issue, but MagSeed. Again, MagSeed is currently being practiced in the UK and it is under study. This is a small magnetic device which consists of a cylindrical non-radioactive paramagnetic steel and iron oxide. And using a Centimag device, and this is the probe, we can actually, you get an audio tone. you get an audio tone which tells us if you're close to the lesion or far away from the lesion with a numeric code on the Centimag device. Based
Dr.
on
Pragya,
that,
the time is up. Could we come to the conclusion slide, please?
I need 2 more minutes. There are a lot more slides, the names that I have to come up with. Yeah.
No, we need to end it because other people also have lectures,
Okay,
right?
well, margin probe is the other device which is generally used to check the margins, and this is being currently used in India as well under studies. Well, these are all the emerging technologies which we really don't have much evidence for. Optical coherence tomography, microcomputed tomography, ex vivo MRI, bioimpedance spectroscopy, Raman spectroscopy, chemical probes. So to conclude, which method is better? We really don't have complete evidence, but as per standard of care, frozen section analysis, imprint cytology, and ultrasound-guided lumpectomy lowers the margin rates. And cavity shave and margin probe have also proven to be effective. Although the intraoperative pathological diagnostic techniques such as frozen section and imprint cytology have gradually gained recognition as conventional tools in BCS that lower the positive re-excision rates and eliminate, as demonstrated by a number of studies and meta-analysis. But most of the centers currently do not use these because of resource constraints and lack of experienced staff. We need non-pathological methods to come up to help us gauge the margins intraoperatively, or AI, artificial intelligence algorithms, without the need for well-trained pathologists. Sorry, this was just too much to cover in 15 minutes, but thank you.
Thank you, Dr. Pragya. Any questions for her?
No, there are no questions in the chat.
Okay. Yeah, thank you. So we'll go to the next topic. I invite Professor Sandeep Mathur, who is a professor at the Department of Pathology at AIIMS, New Delhi. He is serving as the editorial member and reviewer of several reputed international journals, and also he's a has many international affiliations. And his special interest is on breast cancer and gynecological cancer. So I invite him to give his talk on specimen handling and breast histopathology report, the essentials of it. Thank you, Dr. Sandeep. Over to you.
Yeah, a very good evening to all of you, and thank you. I thank the organizers for having given me an opportunity to share my thoughts on this topic. So I was allotted a specimen handling and breast histopathology report, the essentials. So given the time constraint of just 15 minutes, I will try to just go through the important things. I hope I'm clearly audible.
Yes, sir.
So the outline of my talk is going to be about the diagnostic tissue, pre-op tissue, basically the FNA or the biopsy and handling of the biopsy tissue and the resection specimens, the specimen workflow, gross assessment, processing, and the nuts and bolts of the pathology report. Now, you know, diagnosis of breast lesion is generally done by any minimally invasive breast biopsy procedure, which could, but before doing that, one needs to have a proper triple assessment so that the biopsy is done from the significant or the lesional area, and you know there is a good concordance with the clinical and radiological findings as far as the pathologist is concerned. So you have still in our country FNAC, which is fairly popular, but most of the good and the big centers have shifted now to core needle biopsy, including ours. We hardly do FNA these days, and of course vacuum assisted biopsies. Regarding FNA, the only thing everybody knows about the advantages and disadvantages, the only thing I'd like to say is that one has to ensure adequate cellularity, avoid air drying artifacts, label the slides correctly, there should be no mix-ups, and this is safe only in the hands of an expert cytopathologist, so who knows the limitations of FNA. Regarding core needle biopsies, it is very preferable to have fewer but very large cores rather than multiple fragmented cores, because that disturbs the spatial organization, causes architectural fraying and all. So that makes interpretation difficult. So the usual must-dos are there, accurately labeled to avoid any mix-ups. There should be a proper requisition form giving the prior history, prior biopsy, the radiological findings, what kind of device was used, site, size, etc. These are all standard good practice things which are needed. So an intact biopsy would usually be heavy, especially if it's a tumor biopsy, and sink in the container and not float. Floating biopsy is usually fat. A specimen radiograph will tell you if the biopsy is taken from a cluster of microcalcifications. We usually need 2 to 4 good cores to give a good diagnosis, and you may need a greater number of sample or tissue for a complex lesion. Now, the most important is the pre-analytical principle that the cold ischemia time should be less than an hour. And the duration of fixation is recommended to be 6 to 48 hours and should never be more than 72 hours. For ERPR, ideal is 8 hours, and for HER2/neu, if I fish, it is 2 hours. And the amount of fixative which you use is the standard, the rough guide is that it should be 10 times the volume of the specimen in a ratio of 4:1. Now, regarding the cold ischemia time, for ERPR and HER2/neu, it should be less than 1 hour. Formalin fixation time for ERPR can be up to 72 hours, but for HER2/neu, it should be ideally less than 48 hours. And for HER2/neu, optimal specimen is actually resection because there is some heterogeneity in the HER2/neu expression which is seen, and HER2/neu can be repeated on resection if the tumor is grade 3. There is an invasive tumor in the core needle biopsy which was small. The resection contains some different looking areas, and there is a quality concern related to the HER2/neu performed on the core needle. So these are very important. That's why I'm taking some time to go through this. They're the factors which includes predictive biomarkers, because after all, the future treatment, the nature of the surgery, etc., will all depend on these. So there are a lot of pre-analytical, analytical, and post-analytical things which are need to, I don't have the time to go to the details of that. That's a topic in itself. So if you have a delayed fixation, you can have autolysis, tissue breakdown, false mitotic count, difficulty in assessing many morphological features, and loss of antigenicity for the biomarkers. Another important thing for the pathologist to have a good radiohisto correlation. So there are various scenarios which can be there, which require you to get in touch with the radiologist and clarify matters, and if required, go for a repeat biopsy, especially in these borderline lesions with borderline finding and when there is a gross discordance. Now, the importance of knowing where the calcification is, if you have a biopsy block radiograph, you would know that your lesion, suppose this black mark is the significant lesion, but your section is only going through the small benign calcification dots. So you may not actually be visualizing so it's important to know how deep is the lesion, which radiology can help you. You can see DCIS in the biopsy, but one will be aware that many of these will be upgraded to invasive cancer. So they especially in these mammographically detected lesions, they are fairly common these days. So in around 15 to 35% of the patients, they may be upgraded. Lower upgrade is there with the WAB. So we usually grade into low, intermediate, and high grade depending on the nuclear features mainly. This is an example of a high-grade DCIS where you see this comedonecrosis in the center. It is demarcated by the myoepithelial markers. You can classify them into architectural subtypes, most of which do not have any prognostic significance. So if you see an invasive carcinoma in a biopsy, there is a very good correlation with the subsequent resection. The grade may sometimes be underestimated as a result of low mitotic rate being seen. But if you are going to anticipate a NACT, then you have to give full range of information on the biopsy itself. So there is various studies have shown that the core needle biopsy is fairly accurate in all aspects of breast reporting, and the false negativity rates are very low. There are some lesions by virtue of which their nature, they require excision, like papillary lesions, mucinous lesions, some spindle cell lesions. So these are biopsy is insufficient to give a final diagnosis on these kind of lesions. And sometimes common diagnostic errors in breast pathology are, there are various lesions which can give rise to a false positive, like classical radial scars, sclerosing adenosis, a microinvasive carcinoma. Radiotherapy effects can be mistaken as a positive. And then false negative diagnosis, like classical example is lobular carcinoma and tubular carcinomas. Papillomas are lesions which are seen generally in the large or the smaller ducts. They may be multiple. The distal papillomas are considered more significant. These are difficult lesions on biopsies and need a complete excision. So don't be surprised if your pathologist gives you a report which doesn't say much about the exact nature of the lesion, because the periphery of the lesion in the papillary lesion is very important. Now, you are well aware about the relative risks of these lesions. I won't be able to go into the details of these lesions, but we use immunohistochemistry to differentiate between the other differential diagnoses with which these lesions are commonly confused. An atypical ductal or hyperplasia or a low-grade DCIS would be strongly full house ER positive. That's what helps a pathologist in determining. Lobular lesions are another thing which may have a tendency to be missed, especially in a biopsy. So they can be multicentric very often, and these are the morphological pictures of a atypical lobular and lobular carcinoma. This is defined by the absence of E-cadherin. The E-cadherin marker is lost, and that's what helps. So coming to prognostic and predictive biomarkers, these are the well-established markers, ER, PR, HER2/neu, which have therapeutic implications. And as I already told you, they are influenced by the fixation, etc. So we usually typically use the ALRED scoring system for based upon the intensity and the percentage they are classified. A score 3 and above is considered positive. For HER2/neu, you have 3+ or equivocal. For equivocal cases, we go for FISH. So this is an example of a normal nucleus which have the 2 green and 2 red dots, and this is amplified on FISH, where you see these numerous green dots. They represent the amplification of the HER2/neu gene. Now, following chemotherapy, there can be an alteration in the receptor status. This is more common with ER and PR than HER2/neu. The proliferation rate is another important prognostic biomarker which we do, which is the Ki6, which is determined by the Ki67. You can do a surrogate molecular classification into luminal A, luminal B, basal-like, depending on by doing a set of IHC markers. Of course, it's not correlating exactly with the genomic classification, but these are sometimes helpful and practically useful in situations. We use a lot of immunohistochemistry for sorting out some problems in histopathology. So this is the part about the biopsy, which I just talked about. And now straight away going to the handling of the resection specimens, you can get a wide variety of resection specimens, which as surgeons you are very well familiar with, so I won't be reading out these. Then the other specimen, most important in the breast resection, is the regional lymph node sampling, which may be a sentinel node, low axillary, complete clearance, intramammary nodes, which are counted with the axillary, or sometimes rarely supraclavicular and internal mammary nodes as well. So the measures, important measures by the surgical team. First of all, I would like to say avoid frozen section in the following situations. When you have small regions, the resection margins look grossly free, and a breast excision specimen is removed because of mammographic health, because that's likely to be a difficult case, something like a DCIS or something, which a frozen won't help. And definitely a frozen should not be done for a diagnosis, primary diagnosis. And they should be accurate listing delivered to the pathologist intact. So you should not cut the specimen, especially the deep margin. And this is sometimes these days being done for research blocks and all tissue, etc. So that is very important, that it should not be cut in a manner that distorts the final evaluation. These are the standard clinical details which need to be provided for the pathologist ideally. And of course, the radiologic detail, if there is any clip in a case of NACT, that's very helpful if it is mentioned on the form. Now, regarding the processing, the pathologist will orient, assess the margin, measure the dimension, ink the surface, serially slice, and he will ensure adequate fixation in proper formalin solution. So these are the standard things: the tumor size, any other suspicious areas, perpendicular sections from ink margins, and non-tumor candidates, the nipple areola complex, skin, and in case of NACT, the entire tumor bed. Then, of course, followed by the meticulous axillary lymph node dissection, where we submit the largest, as many nodes as possible. So this is the standard workflow in a pathology lab. You examine the breast specimens, note the dimensions of the specimen, including the skin, nipple areola complex. Note down any findings on the skin. The suture tag is standard, short superior, long lateral, which all surgeons follow. The specimens, again, I would like to emphasize, should not be cut by the surgeon. From the deep margin, we paint the entire margin and then take serial slices with a very sharp blade. And in our department, we keep it for fixation overnight and do the final grossing the next days. The usual process followed is the sagittal sampling and not the coronal slicing, although this is also described. And you can have multicolored staining for the margins. Okay, so that is also possible. And these are the standard things in the tumor: the location, size, shape, consistency, border, distance from the NAC and the skin and the base, the deep margin, the calcifications, if any noted, DCIS, prior biopsy, lumpectomy cavity, fibrosis, etc. All these are very important. Then the sections which you take is the largest cross section of one slice, and one section per centimeter of the tumor for large tumor, and the base may be included if it is closer to the tumor size, as such. The overlying skin, NAC, are the standard sections which we take. For multifocal tumor, you have to take both the tumors as well as the intervening parenchyma, because if it is free, then they are counted as different tumors, and the largest tumor should be measured as the T size. These are the common fixators which are used. Formalin is the standard. And this is the pathology lab picture. You can see the tissue processor. This is the embedding station. This is the microtomy being done. And this is the final staining using an automated tissue stainer. And when you give the report, you do a histologic assessment, which includes the histologic diagnosis, the size of the tumor, grade, lymphatic invasion outside the tumor, venous invasion, margins, skeletal muscles, skin involvement or not, nipple condition, whether there's Paget's disease, then about the intraductal component, all the details, and finally the lymph nodes, which includes also the maximum size of the metastasis. The key issues in grossing are the exact tumor size, duct DCIS, surgical margin, and lymph nodes. The size may be downgraded or upgraded on microscopy. So the gross assessment is not the final, or the clinical assessment is not the final. It is very important to have an accurate tumor size. So the tumor size measurement, you measure the largest focus. The satellite foci are not included. Tumor more than 5 millimeter apart are considered separate tumors. They may be multifocal or multicentric. Multifocal if in the same quadrant, and multicentric if in different quadrants, more than 5 centimeter apart. In post-neoadjuvant chemotherapy samples, there is a separate some considerations which are there. So you also serially slice, then you identify the tumor bed, and ideally you should map the tumor bed and kind of take the largest area in the tumor bed and map it, as you can number it so that you know exactly what was the extent of the tumor. This is very important, and we follow this in our department. So depending on how big the tumor is, if it's a small or the large tumor, you sample accordingly. Maximum blocks to be submitted around 25. There are some guidelines from the US FDA, but the RCPAP does not make any such recommendation. But of course, you can always take additional samples if needed. There are differences in the sampling of the tumor, because in the RCB scoring, they include the fibrotic area in between for tumor size, whereas in the AJCC, they exclude the fibrosis. So depending on there are various systems for evaluating neoadjuvant therapy. We follow the Miller Pain and the RCB score, which RCB is a calculator, online calculator by MD Anderson, and this is the Miller Pain, which most of the surgeons may be familiar with. Extent of the tumor, you only call tumor 4D when there are tumor in dermal lymphatics associated with inflammatory carcinoma. Otherwise 4B if there is a satellite nodule which should be grossly seen along with skin ulceration. If the tumor is present in lactiferous sinus, or just a tumor present in the dermis or epidermis, does not qualify for skin involvement. And importantly about the margins, as I told you, you can have multicolored margin. There are various dyes which are available. Inking is very important because you can see them under the microscopy. We usually don't do multicolor because it's very tedious. And the margin up is positive when there is tumor on the ink. Close margin less than 5 millimeter. For DCIS, more than 2 millimeters. It can be called unifocal if there is one focal area of carcinoma at the margin less than 4. Multifocal if 2 or more foci of carcinoma at the margin. And extensive when carcinoma is present over a broad front more than 5 millimeters. So there are various ways of taking margin along with the tumor: 4-quadrant margins, circumferential margin, and when there is a specimen, then you can, if it's far away, then you can take them separately, tumor and the margins. And if it's close to one of the margins, you can take it along with the tumor. And as I told you, tumor on the ink is the most important. Regarding axillary lymph node dissection, serially sliced from medial to lateral, at least 10 lymph nodes, the more the merrier. And if no node is identified, the entire fat should be submitted. A grossly positive lymph node, you can just take one section. In a negative node, every 2 millimeter you have to take. And the largest contiguous focus is measured. Yeah, I'll just finish.
Yeah, thank you.
You were well aware about the definition of metastasis. Macro, we call it when more than 0.2 millimeter. Isolated tumor cells have no clinical significance. If you detect a nodal metastasis by FNA, it is classified as macro, irrespective of the size. So this is an example of an extranodal spread you can see here. This is a macrometastasis, this is a micrometastasis, and sometimes you can use IHC to detect that. A sentinel node has to be sliced at 2 millimeter interval. It should include the perinodal fat to document extranodal extension, 1 node per block. And you have to then histologically subtype the tumor. There are some histologic subtypes which have a better prognosis, like the mucinous, tubular. You have to grade based upon this tubule formation, nuclear size, and the mitotic count. These are examples of low grade 1, grade 2, and the bottom right is the grade 3 tumor. A microinvasive, when the invasion is less than 1 millimeter, which You also described the till these days, the tumor infiltrating lymphocytes, which are now known to have prognostic significance. And in the surrounding breast, you would talk about the DCIS, extensive, whether it's extensive or not, that means more than 25%, whether there is blood vascular and lymphovascular perineural invasion. And I think I won't be going into molecular classification because Dr. Mala has already talked about all these, and that staging as well has been covered. So I think I will just end my talk here with the take-home message that it is very important to have a communication between the members of the breast and multidisciplinary team. We need to understand each other's strengths and limitations, and important to have SOPs at the level of handling biopsies as well as the resection specimen, both at the surgeons and the pathologist ends. And it is useful to have a structured requisition forms so that automatically all that information is provided and there is no cause for complaint at the pathologist end. And a customized synoptic pathology report should always be included to improve the quality of report and for the ease of the treating medical oncologist or the surgeon. Thank you very much.
Wonderful talk, Dr. Sandeep. Thank you for an extensive talk. And there's so much of practical, even I was not aware that there's so much of work which goes and about the multicentricity and the fixation. It's amazing, Dr. Sandeep. Thank you. Thanks a lot for your talk. Any question for Dr. Sandeep?
Sir, there are certain questions in the Q&A box. Somebody has asked how many minimum and maximum lymph nodes are required in the grossing of
yeah, so regarding lymph nodes, we always tell our residency, the standard is that our surgeon will always write back to us if we report less than 11 nodes. So a 10 node is also like a borderline thing. So we usually exceed the number 10. But it varies from specimen to specimen. But ideally, in any good center, you should be able to dissect out all the nodes, and a good surgeon will always remove more than 10 nodes, unless, of course, there's exceptions are where there's a NACT being given or something where the nodes may be lesser or fewer. So the more the lymph nodes, the better it is, because it's a very important prognostic parameter. And one question I can read here is, sir, can you please explain what is tumor bed? So tumor bed is something which is used for in post-NACT samples, where when we slice the specimen, any contiguous area of gray-white area of fibrosis, which may include the tumor as well as the, after neoadjuvant chemotherapy, there is a lot of fibrosis. So that's the tumor bed. So our intention is to sample the entire tumor bed. So because it more or less corresponds to the original tumor size prior to chemotherapy. I hope that answers the questions. Granulomatous mastitis does not mimic carcinoma breast, maybe clinically sometimes, but for a pathologist, no. I think I'm done with the questions.
Yeah. Thank you, Dr. Sandeep. Thanks a lot.
Thank you.
So we'll go ahead with the next talk. It'll be given by Professor Rosina Ahmed, who is a consultant breast surgeon at Tata Medical Center, Calcutta. So she's FRCS from England and also has a distinction awarded by University of Sheffield for her research. So over to you, Dr. Rosina. Her topic is Let's Deconstruct to Reconstruct regarding the breast anatomy for an oncoplastic breast surgeon. Dr. Rosina.
Thank you very much for inviting me to speak today. This topic has been put quite interestingly. Let's deconstruct to reconstruct. Let's see what it all means. Sorry. So, oncoplastic surgery is the talk of the hour. There are lots of techniques in oncoplastic surgery, perhaps something quite simple such as a round block oncoplasty, as we did for this patient with a right breast cancer. There are other older techniques using a pedicled latissimus dorsi flap following a mastectomy, which is also an oncoplastic technique, which is still quite commonly used. And then there are newer techniques, such as a technique for this left breast cancer where we used an intercostal artery perforator flap. And finally, not new, but more complicated techniques, such as this patient who had a therapeutic mammoplasty on the right with a left symmetrization procedure. And for all of these, we need to understand the anatomy of the breast through and through. So what are we trying to achieve in oncoplasty? Once we understand this, we understand the anatomy that is going to take us there. First, most important, we want an oncologically safe outcome, both with the breasts and with the draining lymph nodes. We need to be concerned about vascularity. So the remaining breast tissue, the nipple, and any flaps that we might use need to be adequately vascular. We should be concerned about sensation in the nipple, and we want an aesthetic breast shape. The first thing to understand with breast anatomy is to understand the lobular architecture of the breast. Now, this is quite important because we must remember that breast cancer is most commonly ductal, and it occurs within these sort of triangular sections or cylindrical, conical sections of breast tissue, each of which has a duct which leads towards the nipple. Breast cancer in the more distal ducts may extend along the ducts towards the nipple, and sometimes conditions such as ductectasia that may mimic breast cancer in the clinical situation may also give changes in a sort of radial direction which follows this lobular architecture. We describe the breast in 6 parts, the central part and 4 quadrants, and also the axillary tail. But more commonly, we now talk, when we do oncoplasty, with a clock face sort of description of where tumors are in the breast. And the reason we use this is because of the description of the breast, because of the lobules in the breast. It's important for multifocal tumors. It's important when we think of excising tumors that are close to the nipple, because we may need to consider that there might be extension of the tumor along the duct towards the nipple, and we may actually need to consider doing a nipple core biopsy during the surgery, a frozen section biopsy, to see whether we have residual tissue in the duct leading towards the nipple, because that might modify the way that our oncoplasty proceeds. I'll just show you one mammogram to try to explain this lobular architecture to you. This is a patient with DCIS, and here on the right of the screen, you can see these changes, pleomorphic calcifications of DCIS that spread through one entire lobule in this patient, extending from the periphery of the breast towards the nipple in a segmental nature. This is quite common in DCIS, and it's important because this is based on the lobular architecture of the breast. The next thing to understand is the fascia, which surrounds the breast. Well, there's the muscles. I don't want to go into the names because I think that's fairly first-year medical student and everyone's aware of that. But the breast is enclosed within layers of the superficial fascia. So there's a superficial lamella that goes superficial to the breast and a deep lamella that goes deep to the breast, enclosing the entire breast within it. Another part of the fascia are the Cooper's or suspensory ligaments of the breast. These are important with oncoplasty because when the superficial layer of these suspensory ligaments is involved with the tumor, we get changes in the skin, and that may change the incision that we need to make because we may need to excise the skin over the tumor. If these Cooper's ligaments are not involved, it may be quite possible to preserve the skin following the tumor, over the tumor. With the fascia, the most important, and in this entire presentation, this is the most important slide. There is a fascial structure within the breast, which is called the septum fibrosum. It was only described about 25 years ago, and it runs at approximately the level of the 5th rib, divides the breast into a superior part and an inferior part. But most importantly, what this structure does is it carries vessels and nerves from the chest wall towards the nipple. And I'm going to show you some more examples about, related to this as we go on in this talk. This is another representation from the same paper, which was published 1998. And that shows that there's a sort of a plate-like fascia that extends from medial to lateral across the breast. And this is the level, the fascia that carries blood vessels and nerves towards the nipple. The arterial supply of the breast, well, traditionally, there are a number of vessels that all arise from the subclavian artery that later becomes the axillary artery. So there are the medial vessels which come from the internal mammary artery. There are the superior vessels which come from the thoracoacromial artery, the axis, and that gives off pectoral branches, which become mammary branches. And there are lateral branches, lateral vascular supply, which come from the lateral thoracic artery. But again, to go back to the last slide, it is important to understand the arterial supply in a three-dimensional manner and not just to depend on these named arteries. So there are groups of arteries that are in the superficial plane in the breast, and there are other arteries which pierce the breast and come through the breast from the deep plane. And it's very important to understand these groups as we do different procedures in oncoplastic surgery. The main superficial branches are the perforators from the internal mammary. Now, when you do a mastectomy, you will see the branch from in the second space that comes from the internal mammary artery. It's a large artery, and it's important to try and preserve that artery, even when you do a mastectomy, because it really contributes to the vascularity of the flap. Also superficial is the superficial branch of the lateral thoracic artery. So these are branches coming in from the medial side and the lateral side. What about the deep ones? There are intercostal artery perforators from the second to the sixth spaces, and these pierce the breast and they come through the breast. There are also in the superior part of the breast, we see the pectoral branches of the thoracoacromial artery. And again, we come across this in mastectomies. As we dissect the superior flap, there is a big vessel that passes through the breast tissue and then up into the subcutaneous vascular plane. And that comes from the thoracoacromial artery and is part of the supply of the superior part of the breast. There is also deep branch of the lateral thoracic artery. The branches from the intercostal arteries, particularly from the fourth intercostal, run in the fascial plane that I was talking to you about earlier. The vascular supply of the nipple needs to be looked at separately. It is very richly supplied with blood vessels. There is a circular vascular plexus around the areola, deep to the areola, and it's supplied from vessels which arise both medially and laterally, and both from the superficial and from the deep planes. So the vascular supply of the nipple is actually quite a secure supply, but it needs to be taken into account in any operation that preserves the nipple. The venous drainage more or less follows the artery, and there's nothing special to say about this, so we will move on. We will also very briefly touch on the lymphatics. This is a diagram from actually the 1900s. This is one of the original diagrams drawn by Sappi, who described the lymphatic plexus of the breast. We are all aware of sentinel lymph nodes and how the lymphatics beyond the sentinel lymph node distribute themselves to other parts of the breast. And as time goes on and we use fluorescent techniques, we're getting more dynamic information about this. But the lymphatic supply is not the focus of today's talk, so I'm going to pass on to this and carry on with the issues that are important for oncoplastic surgery. It's important to know the nerves. So the sensory nerves of the breast come in the superior part of the breast from the supraclavicular nerves, which are coming from the C3 and C4 nerve roots, and they have medial, intermediate, and lateral groups. And there is a very important segmental supply to the breast from each of the intercostal spaces, from the cutaneous branches of the intercostal nerves. I'll remind you again of the septum fibrosum and try to explain what happens with an intercostal nerve, which runs in an intercostal space. It gives an anterior cutaneous branch, which runs subcutaneously in the medial part of the breast. It also has a lateral cutaneous branch, which divides into two parts. There is a superficial branch which comes along the lateral subcutaneous plane, and there is a deeper branch which pierces the breast and moves through the breast. And it is the branch, this deep branch from the fourth nerve, that runs in this septum fibrosum and runs up towards the nipple. This same concept is explained diagrammatically here. So there are subcutaneous branches, and there is a deep branch piercing the breast and passing up towards the nipple. Let's take a few real life examples and try to apply these principles of what we just saw. I'm keeping the picture of the septum fibrosum up there as I explained to you the round block technique. So this is a technique which is used for, may be used for tumors in almost any quadrant of the breast, where we separate, have two concentric incisions around the breast, but only at the level of the epidermis. The dermis itself is divided at the layer of, at the position of this outer concentric circle. We don't always divide the entire circle. We use the part of the circle which actually gives us good access to the tumor that we're trying to remove. But actually, it is possible to divide the entire dermis in this entire outer concentric circle. How does the nipple then preserve its vascularity? It preserves it through the circular plexus, which is deep to this part of the breast. And very importantly, it preserves, the nipple vascularity is preserved through the branches that come through the septum fibrosum and through the deep part of the breast and come up towards the nipple. Let's have a look at a more complicated surgery, which is a therapeutic mammoplasty. So here's a patient with very large breasts, as you can see. Her tumor is marked here, and we've also marked her wise pattern skin excision. Next, we have to decide how to preserve the nipple. What is the vascular supply of the nipple that is going to allow us to do this surgery and come up with a cosmetic answer? Well, the nipple has vascular supply coming from 4 different directions. There's the vascular pedicle to the nipple from the superior direction, which comes from the pectoral vessels, which is a dermal or dermoglandular pedicle. Then comes the superomedial pedicle, which is coming from the internal mammary artery and runs in the subcutaneous plane. Next comes the inferior pedicle, which comes from the 4th or 5th intercostal arteries and comes deeply through the breast and runs in the fibrous septum that we've been talking about. There is also a lateral pedicle, which comes from the lateral thoracic, and it runs both superficially and deep via the septum. So as you can see, the nipple is supplied with vessels from all directions, and the pedicle that we choose as oncoplastic surgeons depends really on the location of the tumor that we need to excise. In this patient with her superolateral position of tumor, both the superior and the lateral pedicles were not suitable. And we have a choice here. We could use the superomedial pedicle, or we could use an inferior pedicle to preserve the vascularity of the nipple. If you remember, I also told you that we want to achieve a sensate nipple. So along with the vascular pedicle, we need to think of the sensation of the nipple. So there are 2 types of nerves running to the nipple. There are the vasomotor nerves, which run in the fibrous septum. And there are also sensory nerves to the nipple, which again run in the fibrous septum. Mainly they come from the 4th intercostal nerves.
Dr. Rosina, 1 minute left.
Okay, there are some superficial branches, and laterally there are deep branches which come through the fibrous septum. Here's another example. There are vascular pedicles and there are nervous pedicles. We choose the ones most suitable. 1 minute to talk about the last thing, which is when we want to do volume replacement using perforator flaps. There are many named flaps. They are the perforator vessels pierce the deep fascia. They have branches to each other at least 2 different levels, and they form what are called perforasomes. Here are a few examples for you. This is a patient with a tumor here, which needed to have a replacement based on these branches, which came from the lateral intercostal artery. Here's another patient with inferior tumor in the breast, where we use branches, perforating branches coming from the anterior intercostal arteries. Here is the last patient actually with the combined vascularity of the flap, which is combining the lateral thoracic and the LICAP vessels as perforators. I just want to remind you that every time you do a mastectomy, this is for people who are not commonly doing oncoplastic surgery, but every time you do a mastectomy, you see these vessels. If you practice looking at these vessels and understanding where they come from while you do the mastectomy, then it is a short step, a small step to doing oncoplastic surgery. There's the lateral thoracic vessels that run in the direction shown, and there are the perforating vessels from the lateral intercostal vessels that run round the edge of the pec minor and pec major. We commonly just diathermy them as we do a mastectomy, But those are the vessels that we are looking for. Here's another example where actually the vessels are visible as we described. It's a small step from mastectomy to oncoplasty. It needs a little training, but it needs an eye for the anatomy from the very beginning. Thank you.
Wow, great talk, Dr. Razina. Thank you. It was like most people would have understood what oncoplasty is, and you made it very simple. Most doctors find it very complex, but the way you gave the lecture, I mean, it is very nice. Thank you.
Thank you.
Any questions for Dr. Razina? Right. So we go on to the next lecture given by Professor Gaurav Agarwal. He is a professor at the Department of Endocrine and Breast Surgery at SGPGIMS Lucknow. So he is the Tom Deeb International Clinical Fellow. He has been awarded from the University of Sydney in Australia. He has received various international fellowships, and we know him very well for he has given multiple lectures both on national and international forum. And more importantly, he is the past secretary and also the current president of the Breast Surgery International, which is an affiliation of the International Society of Surgery. Over to you, Dr. Gaurav Agarwal. He'll be talking on about starting an oncoplastic program. Professor Gaurav.
Good evening. Yeah, thank you, Ashwin, for that introduction, and thank you, the organizers, Dr. Anand Mishra, Dr. Kulranjan, Dr. Zambre, for this invitation. And if I may straight away share my screen. Is my screen visible and am I audible well?
We can hear you, Dr. Gaurav. We can't see your screen yet.
Not yet?
Yeah, now we can see it. Please go ahead. Thank you.
Okay, thank you. So I guess I've been given this task to discuss more of an organizational or conceptual topic and not a surgical topic per se, starting an oncoplastic breast surgery program. And so my talk is going to be more of a philosophical one. I'm not going to show you any data, not even any surgical techniques and results, but just share some thoughts on how one can graduate from a simple non-oncoplastic practice in breast surgery to oncoplastic breast surgical practice, and how one can perhaps start a training program too. Well, a journey of 1,000 miles certainly starts only with a single step, and Rome is certainly not made in a single day. One need to know what is that first step that one needs to take when in context of starting an oncoplastic breast surgical program. And to my mind, the very important, the vital, most important first step is to have the conviction or the zeal to start practicing oncoplastic breast surgery. That self-belief that you want to do this and you can do it has to emerge out of conviction of safety and utility of these procedures. So to say that if you're yourself not very convinced that breast conservation and oncoplastic procedures are good for the patient, you would not be able to convince your patients and your team who would help you doing these. It has to come from the commitment to provide the current state of art, to provide the current state of art treatment to your patients. And if you're a teacher or a faculty, the conviction to provide the current state of art training to your residents and the fellows. But there are a few prerequisites before you can jump onto the oncoplastic bandwagon. One has to have a solid foundation of the basics of surgery, breast surgical oncology, oncology as a whole, pathology as it is applied to breast cancer, and a fair bit of knowledge about breast imaging. And while it is good to rely or to collaborate with various specialists, including pathologists and imaging, there is a need for a surgeon to learn a fair bit of these himself or herself as well. As a breast surgeon or a surgeon operating on the breast, one has to develop some sort of a team, a multidisciplinary team, without which you would certainly not be able to offer optimal care to your breast cancer patients. So team building is of paramount importance. And as the surgeon, who often is, or rather as a rule, is the first point of contact for breast patients, it is by natural, it's quite but natural that the surgeons are the leaders of these MDTs. But what does it take to begin oncoplastic breast surgical practice? It actually is a step beyond basic breast surgical practice. It cannot be the first step in your surgical practice. Oncoplastic breast surgery has to be a logical next step once you have mastered, at least to a certain extent, the basic breast surgery. One has to know, respect, and practice the basics of breast surgery and breast oncology, and never compromise on those. We have to recognize the fact that oncological principles are of paramount importance. Cosmetic outcomes are also highly desirable, but never at the cost of oncological safety. For example, to achieve a small volume excision, to improve the cosmetic outcome, one cannot compromise on the width of the margins. Similarly, it has to be a commitment from all people practicing this surgery that we have to respect the patient's desire. After all, it is her life. But at the same time, one has to know where to draw a line. For example, when to say that you would not be able to conserve a breast, or so to say, no conservation for breasts which are unconservable. Breast surgery and perhaps all surgical practices are teamwork, and one is as strong as the weakest link of the team. As the breast surgeon, one has to be the leader of the multidisciplinary team to inspire and to stimulate the other members of the team to train and to strive for something better. And oncoplastic breast surgery is certainly all about going one step ahead, or going the extra mile to offer a better outcome, both oncological and cosmetic outcome, to the patients that you're dealing with. One should invest in collaborations and at the same time with some healthy competitions. Collaborations can be with another surgeon, another breast surgeon, perhaps a surgical oncologist, or any surgeon with similar goals in life. And in context of oncoplastic breast surgery, if you have a buddy, if you have a fellow surgeon who wants to achieve similar kind of results, perhaps it is best that you invest in this collaboration, and perhaps also start a healthy competition or a healthy strive to excel. Whatever I'm talking is in context with a general surgeon or a surgical oncologist or a breast surgeon with general surgical background taking on oncoplastic breast surgery. We have, as general surgical trainees at certain stage, undergone some bit of plastic surgical training. But of course, you cannot match the acumen or the skills of a fully trained plastic reconstructive surgeon. There would be a few procedures and at times when you would require the skills and expertise from a fully trained plastic surgeon. And it makes sense to collaborate with one to offer or to achieve good quality outcomes or cosmetic outcomes for your patients. Similarly, it would be good to have a radiation oncologist and a medical oncologist, preferably one who excels and who is an expert breast oncologist, because there would be a number of nuances that you need your team, including the oncologist, to be very clear about when you deal with, or when they're dealing with patients whom you have performed an oncoplastic breast procedure. This is, I mean, in my own practice and in my own experience, it took us quite a while to sit with the radiation oncologist on the planning consoles to show them what would be the tumor bed, what would be the margins they have to include in the boosts, because unlike a conventional breast conservation surgery or a simple mastectomy or a modified radical mastectomy, post-reconstructive or post-oncoplastic surgery fields are so different. And so imaging using high quality CT scan planners and discussing with the radiation oncologist is of is very important. Another collaboration one must develop is with a able radiologist, preferably a radiologist like Dr. Smriti Hari, who specializes in breast radiology, and with a pathologist, again, preferably with breast pathologist. I am fortunate that SGPGI gives me opportunity to collaborate some of the best in the business kind of people in all these areas. I feel that this team, the various members of the team, they help us build our own skills and expertise over a period of time by providing constructive criticism of every failure we face. And also, we must uh, celebrate collaboratively the successes we gain. So, what does it take to begin oncoplastic surgery? It does take a lot to learn oncoplastic surgery and to teach. And then, to my mind, the only way to teach well is to learn well or learn sufficiently. Question arises: learn from whom? Ideally, from a guru, from an expert oncoplastic breast surgeon. If you can get hold of one, if you can get a fellowship with that person, or fairly long to follow him or her, learn from his or her skills over a period of time in a formal training procedure, which is perhaps the best way to learn surgery, any discipline of surgery. That's certainly the one way to go. However, not everybody would be fortunate enough to get such fellowships. And in today's connected world, with so many electronic resources to learn from a distance, it makes sense to become a modern day eklavya and learn from a dronacharya. I would perhaps put myself in this category. I never had one on-site, fully physical guru at all times, but I did follow a couple of my role models, Krishna Kloff being one of those, and learned a lot, even from a distance. Though I did visit some of my role models for a short duration of time. But all said and done, you may have undergone the best fellowship training, or you may have had the opportunity to follow the work of one of the best in the business. But the bottom line remains your own zeal, your own commitment to learn yourself and from your team members, your team, your peers, from your own mistakes and your own successes is what makes you what you are finally. Besides, one has to ask, or one has to dwell on what to learn. One has to learn beyond the basics. As I said earlier, it is not oncoplastic surgery is not the first step in breast surgery, or cannot be the first step in breast surgical practice. It has to be beyond the solid basic surgical skills learned over a period of time and honed over a period of time. The techniques that we learn, they need not be out of the word extraordinary techniques, but to begin with, some simple tricks or steps, and gradually one can graduate to new procedures and relatively more complex procedures. Remember, improvement in our skills and in our performance comes in small measurable steps and not always as a quantum jump. Simultaneously, one needs to know and respect the limitations of yourself and your team, because if you did not follow or did not respect those limitations, there is a great deal of chance that you would harm your patients. It is important to start slowly but steadily, taking baby steps before you take the giant stride to take the plunge to do the most complex procedures. And a stepwise progress is what is desired, beginning with simple level 1 procedures, utilizing the basic training in general surgery, the oncological surgery, and plastic surgery that you may have, I'm sure over the next two days, or the audience of this update would be subjected to or would learn from all the experts who are going to speak on various facts about or facets of oncoplastic breast surgery, what level 1 surgical procedures are, what level 2 procedures are. But it's important that we start with simple level 1 procedures, graduate to mammoplasties and level 2 procedures, starting with volume displacement procedures, and then going on to volume replacement procedures, and finally to whole breast reconstructions. The list is endless for someone who is committed to and who is keen on furthering knowledge and skills. One can continue to grow, of course, with some limitations. One must know the limits one has and then the team has. Do not venture into uncharted territories without navigation. And the navigation in this context would be an expert teacher or mentor. One may have an on-site physical mentor, or one may have just you may have help from various videos and online resources. But the bottom line has to be one cannot make the patient pay the high price of one's own failure. One can collaborate to learn new techniques from peers, from experts, but at the same time, be ready to refer a demanding patient and a demanding case to a more capable surgeon or a colleague. There are patients who are demanding, and there are cases which are demanding. I hope that I'm able to make the distinction clear to the audience. There would be patients with not so challenging surgical procedure, but they are non-compromising on the outcomes. And then there are patients with really challenging procedure which is required. Documentation is
Gaurav,
so,
can we come to the conclusion side, please? We have
sure.
just, thank you.
Yes. So documentation is crucial. One has to document all cases well. It is good to learn from your good cases, but it's your worst cases which help you learn the most. And then one has to be one's own good critic. Audit the practice periodically, assess the oncological and cosmetic results, because it helps in introspection, self-appraisal, and course correction. And of course, this is the only way to publish and present your work. So these were some random thoughts that I think are maybe useful for people who are thinking of beginning oncoplastic breast surgical practices and programs, not necessarily a prescription how you go about it, but these are the basic ingredients one has to have in terms of starting oncoplastic breast surgery.
Thank you, Doctor. Thank you, Professor Gaurav. Any questions for Dr. Gaurav Agarwal? Thank you. So we'll come to the panel discussion. Good evening, sir. Dr. Dev. It's my pleasure to invite you for your panel discussion, sir. I'll go through. I have to introduce you. So he's the head of department of All Indian Institute of Medical Sciences and also National Cancer Institute. He is the HOD to 25 years of experience. He is very happy to say he's the president-elect of ABSI, Association of Breast Surgeons of India. He's also the treasurer of the Breast Surgery International. He has various articles and international journals, and he also has written 2 books. Welcome, sir. He'll be the moderator for the panel discussion on treatment master plan in breast cancer. Would you like to introduce the panelists, sir?
Yes, sure.
Okay.
Thank you.
Thank you, sir.
I would like to thank the organizing committee of KGMU.
Sir, we can't hear you properly.
Am I audible?
Yes, sir. You are audible, but we can't hear you properly.
The volume is a bit muted, sir.
Yeah,
Yes.
Now it's good. Now it's good.
Fine. Thank you. So at the outset, I would like to thank the organizing committee of KGMU Breast Update, Dr. Anand Mishra, Dr. Vaishali, Dr. Kulranjan Singh, for giving me this opportunity. We are running a little late. The panel discussion topic is master planning in breast cancer. This is not a routine topic, but equally important in the overall management of breast cancer patients. So we have with us eminent panelists today, Dr. Mrinalini Verma. We'll start with this slide maybe, yeah. She's from Department of Radiology, KGMU. Dr. Sachwati Devas, she's from Nuclear Medicine, RML Hospital, Lucknow. We have Dr. Isha, Medical Oncology Faculty from King George Medical University, Lucknow. Next, we have Dr. Samir Gupta. We have two surgeons. It's a very well-balanced panel. Dr. Samir Gupta, he's Associate Professor, Surgical Oncology, KGMU. We have Dr. Kulranjan from Endocrine Surgery, King George Medical University, Lucknow. And Dr. Chanchal Rana, she's from Pathology Department. She's a faculty at KGMU. So I will just start sharing my slides, if you allow me. Yeah, can we see the slides, Ashwin? Yeah.
Yes, sir. We can see the slides.
Yes, we can see, sir. We can see. Please go ahead, sir.
So I think in next 30-35 minutes, we are going to discuss the important components of treatment master plan for breast cancer. The modern management of breast cancer is complex and challenging. We have seen a paradigm shift from a uni to multimodality management, from a unidimensional to multidimensional management approach, and cancer-directed therapy to a holistic patient-centric treatment approach. So the challenges are numerous. We need to address multiple issues when we deal with a breast cancer patient in the current era. So I would like to ask our panelists, maybe we can start with Dr. Kulranjan Singh. Dr. Singh, what is the need for a treatment plan for managing breast cancer patients? Could you just share your thoughts?
I think it's important to plan it upfront because it's a day of multimodality treatment. Right from every branch has its own importance, right from the pathologist and then how the treatment goes. Some may require an upfront chemotherapy. In some, upfront surgery may be possible, though the numbers are decreasing. And then the radiotherapy, and then this concept of concurrent chemoradiotherapy. So I think when all these specialists sit together, the patient is likely to benefit most. And at the end of the day, all of us are working towards the same goal, that with minimal morbidity, patient has maximum benefit. So I think the need of today is that there should be an pre-formulated treatment plan, and then only does the actual treatment start. It's not like we do one, okay, then we'll think about the next step. I think we have passed that era. So it's very important to have a treatment plan formulated upfront.
Thank you, Dr. Kulranjan Singh. I think you have absolutely highlighted the core issue of need for treatment planning. If you see, when we started our residency 20 years back, the breast cancer treatment is very simple. There's only one surgical option, one chemotherapy option, and one radiotherapy option. That's the end of it. So we need to decide that treatment plan in 5 minutes. But if you see in the current era, the dimensions involved, including the diagnosis, treatment planning, execution, multimodality, sequencing, counseling the patient regarding goals of therapy, psychosocial issues, fertility, familial genetic aspects, follow-up, rehabilitation. There are multiple dimensions we need to address. It is not possible for a single expert or from one single expert from one specialty to handle all these issues. So that is the core need for treatment planning for breast cancer. We have discussed all the options. Now we have plenty of options. The problem is choices. You have plenty of choices, whether you talk of surgery, of systemic therapy or radiotherapy, sequencing, different modalities. So unless you have a consensus, you follow a protocol, it's very difficult to treat a breast cancer patient in the current era. This is a simple chart showing just a treatment algorithm for early breast cancer. You see the plenty of options, the algorithms, various management approaches for early breast cancer. Now we'll move to the second issue. Who should plan the breast cancer management? Who should be the members of a management team? I would like to ask this question to Dr. Samir Gupta. Would you like to share your views regarding the core team or the total team which is required to plan a modern breast cancer management?
Sir, as Dr. Kulranjan alluded to, it's a multidisciplinary treatment now that we follow for most cancers, more so for breast cancer, where very good chemotherapeutic options are successful in very good downstaging of the disease. and where aesthetic outcomes, I think, have become as important as oncological removal of the tumor. So, starting with the surgeon, which in the previous talk, Gaurav sir alluded to, a qualified breast surgeon, it may be an oncosurgeon, an endocrine surgeon, or a general surgeon with interest in breast cancer treatment. But equally important members of the team being a medical oncologist, a good pathologist, and obviously a radiation oncologist
So
and intervention radiologist as well. Yes.
yes. So depending on the expertise available, the place where you are working, you start forming small teams. So we have a list of core members which are mandatory to start a MDT, and we have a big list of supportive and ancillary team. For example, in a breast cancer, the treatment approach currently what we are advising is the MDT, or it can also be called a DMG approach, disease management group. Both are more or less same. And a tumor board meeting is to finalize the treatment plan. So this is the current sort of a teams which can be, you see, it can vary from a core team involving the basic surgeon, medical radiation oncologist, pathology, imaging. Then we have various support services including physiotherapy, rehabilitation, geneticist, nutritionist, breast nurse. It's a huge sort of approach. So can we have some more views from the medical oncology expert here with us, Dr. Isha? So regarding, like, suppose we have a center with limited resources. So what should be the minimum team which you recommend to start a MDT planning for breast cancer? Because not every hospital has got all the resources.
So, for a proper breast cancer management, we discussed we should have a core team which deals with which includes a medical oncologist, a surgical oncologist, or endocrine surgeon, or even a general surgeon, and a radiation oncologist, plus a pathologist, a radiologist, and a nurse, and also psychosocial. For the psychosocial aspect of treatment, there should be a counselor or a dedicated psychologist in the oncology team, which handles a breast cancer patient. And it's important that at the first visit to anybody, if the patient comes, for example, if the patient comes to a surgeon, then the surgeon should discuss the case in the MDT, and if the patient comes to the medical oncologist, the patient should be discussed by the medical oncologist in the MDT. So it's important that before starting therapy, everything should be planned, well planned. That is important so that nothing is missed, because we all work in high volume centers and there are too many patients. So sometimes maybe if we don't work together, then we might miss something. So if it's not possible for us to discuss in a MDT at that point of time when the patient comes to us, no problem. We can easily send the patient on a referral to the other departments concerned. Like at the same first visit, we can send to, if the patient comes to me, I'll send to a surgeon, and I'll send to a radiation oncologist, and I'll also discuss the scans if they are available with the radiologist if I have some doubt.
Yes, Dr. I think you have really highlighted the most important issue, the planning part.
Yes, sir.
Because you see, nowadays patients are in a rush, doctors are in a rush. The patient is diagnosed with breast cancer, go to a hospital. He was told by most of the time by a single physician dealing with the cancer that you have to have this procedure by tomorrow. So that is a wrong approach to treat cancer. That's what I tell most of the patients and physicians. You should spend some time. The first 2 weeks you spend in the proper diagnosis, staging, and treatment planning is very, very critical, and it is going to help in the long-term outcomes of this patient. So that is where lies the importance of treatment planning. So what should be the main objectives? I think we have already discussed some of the objectives coming from our speakers. So maybe we can have a view from the radiotherapy side, Dr. Minalni. So in the complex treatment planning, what are the roles of radiation oncologist to begin with when you start a patient of breast cancer? And what should be the main objective of MDT?
Thank you, sir. Sir, as already all three are highlighted, that main objective of MTTT is the towards the patient care. Actually, I mean, it is the holistic care. Like we have to manage all the things from, like if we have to give a curative treatment, then we should not only focus on the disease part only, but rather than treating the patient. I mean, we have to take care of how much patient can spend or how much days patient can spend in the center, everything. I mean, because radiotherapy, as most of the time, it's the adjuvant treatment part. So, like everything is finished like in 4 months, 6 months, but till then, patient is just exhausted.
Yes.
So we have to take care of everything and make a team plan properly from the starting. Okay, this is the total time, or this is the part, this is the compulsory part of that. Especially if we are conserving the breast, then radiotherapy definitely we have to. I mean, it is a team part, total thing. That's all, sir.
So that's what I was coming to. You see, the basic rationale of a treatment master plan for breast cancer by MDT. It's basically shared decision making. As a physicians, we are not used to making shared decisions. The traditional approach is to make individualistic decisions. So we need to relearn that and try to make decisions as a team. Joint treatment planning. So everybody knows how to treat breast cancer, but for that particular patient, we all need to sit together and plan the best possible treatment depending on the resources and patient wishes and the best outcomes. Joint treatment planning. This is called joint treatment planning. We need to have very well-defined treatment goals. So the moment you start treatment, we have to know what we are trying to achieve. We are trying to achieve a cure. We are trying to achieve a breast conservation. So the goal should be very clear. What happens sometimes, you just start chemotherapy, patient really doesn't know why it has been started. Then the patient lands up with surgeon. He doesn't know whether to do a BCS or MRM. The patient goes round and round and the doctors are also confused. This is basically because of lack of proper planning. There should be a well-defined individual job descriptions. This is very important. Every person should know their job. I am a surgeon, these are my limits, this is what I should speak. Suppose if your patient asks an opinion regarding chemotherapy, I should say that please meet our medical oncologist, or regarding radiotherapy, just ask them. And this is the provisional plan, but they will discuss these issues. The job description should be very clear. And the coordination between team members. There should not be any conflicting views given by different team members. The patient will get confused. Suppose I tell you go for BCS. She goes to medical oncologist, she say go for MRM. So these are the things which we should avoid. So the team member should be on one page. To achieve that, we need to have institutional protocols. The team members should meet regularly. Then they should start offering the MDT services. Treatment coordination and timely delivery is extremely important, because when you start your NHCT, you should know by what time the patient is ready for surgery, so that you talk to your surgeon when they need adjuvant radiotherapy. So you should coordinate this. That is another one of the important goals of MDT. Follow-up planning and rehabilitation. So next, I think, is some of the components of treatment planning. We will go to our pathologist colleague. We have with us Dr. Chanchal. Ma'am, would you like to tell us what are the important components of pathology which are critical in treatment planning of breast cancers?
Yes, sir. So in cases of breast cancer, our role starts from the screening part, where the FNAC is the main modality which we're using. After diagnosing a case as a breast cancer on FNAC, then a core needle biopsy, we can provide the type, the histological type of the tumor. The grade can be given, and most importantly, the intrinsic subtyping or molecular subtyping of the tumor can be done. And based on those intrinsic subtype, the further neoadjuvant chemotherapy plan can be made, that what receptors are positive and in which group that particular cancer comes in. Once the patient has received the neoadjuvant chemotherapy and has undergone surgery, then again our role comes in the final resection specimen, where we have to tell that whether the surgery has been adequate and what are the factors that can determine the further prognosis of the patients. And again, the receptor status can again be changed, because the breast cancer itself is a heterogeneous disease. It's a very heterogeneous cancer which keeps on changing its type. So hormonal expressions might change with neoadjuvant chemotherapy. So again, that needs to be addressed.
Thank you, Dr. Chanchal. I think that highlights the importance of modern pathology in breast cancer management. Now, the treatments are planned based on the molecular subtype of breast cancer. So, Dr. Chanchal has the power to change the entire treatment modality. So, the pathologist is a very crucial member of the MDTs. We are trying to integrate them into the main MDT. We don't no longer treat these patients based on a simple 3-page report or a 2-page report coming from a lab. We want the pathologist to be active, discuss with us, show us the slides, then take an active and integral part in the overall treatment plan. So pathology is going to be very, very crucial, and I request everybody to integrate pathology and radiology as part of core MDTs in our centers. And there are a lot of issues regarding the quality of biopsies, whether to do FNAC, what kind of biopsies, how many cores. There is a continuous dialogue going on between the subjects and the pathologists to improve the quality of the specimens, how to handle the specimens. There are multiple issues. For example, if the preservative or fixation of the tumor is not proper, it can influence the outcomes of PRPR and HR estimations. They have been proven scientifically. So these kind of issues, if you have a dialogue with pathologists, it will help in overall enhancement of the quality of care of patients. So the components of treatment plan includes the tissue diagnosis, staging, initial treatment plan. Once you do the staging and diagnosis, the treatment plan has to be proposed. Then you have to discuss expected common and rare toxicity during the treatment and their management, expected long-term effects of the treatment, who will take responsibility for specific aspects of the treatment, because it's a journey of 6 months for the patient and she will be going through different specialties. So unless you make it clear who are responsible for what components of treatment and what toxicities, the patient will be confused. So we have to make it very clear. Psychosocial and supportive care plans should be provided at the beginning. Vocational, disability, financial concerns should also be addressed. Suppose you offer the patient a targeted therapy, so immediately they will look for funds. So if you have some social worker or some support, it needs to be addressed at the same time. So that is also part of the campaign to support the patient financially, to help them and guide them. Then of course, advanced care directives. So the treatment plan is just the beginning, and that the whole point of care plan is not just to have a document, but to have a conversation. So the team members should meet. That's what I always tell my team members. It is not MDT doesn't mean you sit in a boardroom and discuss. It is part of your routine work. While walking in the corridors, we discuss about patients. Suppose I come across a radiation oncologist, we immediately discuss these are the 2 patients we'll meet you today. Suppose I meet my pathologist, Dr. Chanchal Rana, in a cafeteria, we just remind her that there are 2 specimens we are worried about. So that is actually the MDT is a mindset. That's what I'm trying to bring it. It doesn't mean you sit in a boardroom for 1 hour and after that MDT is over. So if you are a full-time oncologist, we need to integrate this mindset into your routine working culture. So it is walking, talking, and every day you walk in the corridors, you meet in the labs, you meet in the conference rooms. So the conversation has to go on. The conversation has to go on. It is not one-off sort of a meeting. So that I would like to urge all the newcomers and the residents to start practicing this habit. So it is always preferable to have, I would like to ask our panelists in your breast cancer clinics, do you document your treatment plans and goals of treatment of the Kulranjan when you see a patient? So what kind of a documentation you prefer to do in the first instance?
So as of now, we don't have a specific format, but we note down most of the things that are required, as in these, of course, primarily the surgeon's name would be there, but we always have on board the radiation oncologist and the medical oncologist, since there are not many of them in our institute, and we have a dedicated breast pathologist. And in the radiology department also, we have only a few of them with special interest in breast. So it's actually a very close-knit team. So we don't really record those details, but then of course the index stage of the patient, what was the metastatic workup, and then what were the pathology reports. So we, as a routine, we always wait for the true cut or the histopathology report before starting treatment, barring a few advanced lesions where we are sure about the diagnosis, and anyway it would be an upfront chemotherapy that is mandated. We may start with that. So basically it's the index staging with all the results of the metastatic workup and what was the upfront plan that was decided for the patient. And we just mentioned that in sequence, and then the patient starts receiving the treatment. So as on date, being in a government setup tertiary center, most patients would actually present to us in locally advanced or advanced stage. So invariably, chemotherapy is the first thing that they would receive in our department, or maybe medical oncology or even radiation oncology. So that's how we proceed, sir.
Thank you, Dr. Kul. I think he has highlighted, I think, which is, you see, it need not be as per NCCN guidelines or ESMO guidelines or something like that. It is the local resources, what Dr. Kulranjan has highlighted, to gather a team who share similar sort of thought process, committed to same specialty. Then what I would urge is to prepare simple, common disease-specific performance. So these are few examples. We use them in our department at College of Medical Sciences for breast cancer. So there are common files, common performance. So just simple documentation, just one-page documentation. We don't have to have a 2-3 page elaborate history or something. They're like a primary care provider, who is the surgeon treating, who is the radiation oncologist treating, what are the cancer type, location, histologies, various stages, and what kind of surgery you are planning, what kind of radiation you are planning, systemic therapy, whether you are aiming for a curative treatment or a palliative treatment. Simple sort of a 2 or 3 page performer can be easily created in any hospital with 3 or 4 specialists treating breast cancer. So it can be started anywhere. Have a common treatment performer. There is no competition between surgeons, pathologists, radiologists, or medical oncologists. Everybody has got their domain. So we need to sit together, understand, and try to gather the information in a systematic way. So that is where you can create your data along the MDT. So when you form a MDT, documentation is very important. So you need to create a protocol. This is what we'll practice. Suppose we don't have a high-end LINAC. You can say, I would like to use COBOL. That's absolutely fine. You don't have the expertise for breast conservation or oncoplasty, you can say, I will offer MRM. Otherwise, I will refer the patient. But just according to your resources and expertise, prepare a treatment plan, stage-wise protocol, prepare a simple performer. That is how you start a MDT, and everybody should stick to that protocol, treatment protocol. So this culture has to be imbibed in every oncophysician or research. So ultimately, it is the patient's needs, balancing patient's needs, decision making, and diverse professional expertise, bringing people from different backgrounds onto the same page. That is the challenge of MDTs. And the only buzzword is coordination, coordination, and coordination among all the members. So let's go to Dr. Satyavati. We have a nuclear medicine expert with us. Ma'am, nowadays we see a lot of patients coming with PET scans before even a mammogram. So a lot of patients now, PET scan has become so popular. So in the MDT setting, how would you like to integrate like these imaging modalities, and what would be your recommendation from nuclear medicine perspective?
First of all, I would like to stress on this performer which you had shown, that if the clinicians fill that performer and send the patient for FDG PET, then it will be very helpful, because many a times we get false positive, depending on the actually, if the study is not planned properly and is done within a few days of the chemotherapy or hormonal therapy, then you get a flare-up phenomena. And the inflammation which follows after chemotherapy, that may give that may be reported as a progressive disease. So if we have this kind of performer and it is filled and sent to before referring the patient for the scan, that will be very helpful. And actually, nowadays there are two settings. If when we do PET scan in patients who are undergoing treatment, one is in the neoadjuvant setting and another one is in the metastatic disease, treatment of the patients who have metastatic disease. it has been seen that if the PET scan is done even after the first cycle of the chemotherapy, and there is a significant fall in the metabolic activity, then it indicates a good responder. And if it is done after third cycle, then it even indicates a overall good survival of the patient. It can be used to prognosticate even the survival after the chemotherapy. And another thing is there are few limitations of PET. One is if the tumor is not if the initial metabolic activity is less, like in patients with lobular carcinoma, which are not that metabolically active, then PET is not a very good modality in follow-up of these patients. It is very good for triple negative breast cancers where the uptake upfront is very high. So can be referred to.
I think that's what I was trying to tell, because you see, most of the modern tools, they started as a problem-solving tools, but sometimes they can create problems. So unless you collaborate with your nuclear medicine and radiation people or radiology people, MRIs and PET scans can create more confusion rather than solving your issues. So that is where lies the importance of close collaboration. You talk to your nuclear medicine expert, your radiologist regarding the MRI, then come to the patient. And there are a lot of gray areas in the field of oncology which are not black and white. So you cannot convey to the patient that there are certain areas which are not clear. So that we need a consensus among the treating physicians so that these gray areas can be solved before you come and discuss with the patient. So next what I think the radiation part, the pathology, will come back to pathology part, Dr. Chanchal. So the modern breast cancer management, a lot of new algorithms are getting added to the management, like axillary staging, FNACs, node localizations, non-palpable tumor localizations, and biopsies. So the pathology part, what is your advice to the surgeons or MBT people regarding the specimens, specimen quality, handling, because the quality control issues are not often at least. What I've seen, most of the time, the miscommunication, as Dr. Satyavati has said, the information is not given to the pathologist or the imaging specialist what exactly the technical information or how they are supposed to handle the specimens. So what's your take-home message to the surgeons regarding tissue handling, specimen handling, these issues?
So the most important issue that we face sometime is related to the fixation of the specimen. And in cases, usually everywhere formalin is used, but the correct formalin that is to be used is a 10% neutral buffered formalin. So that formalin should have a pH of between 7.2 to 7.4. If the pH is not maintained, in that case, the tissue will not be properly fixed. The other important thing in case of core-needle biopsy is the cold ischemia time. Ideally, the specimen should be immediately placed in a proper formalin solution within 1 hour of performing the procedure, but ideally as soon as it is possible. The timing of fixation should not be less than 6 hours and not more than 72 hours. In either of the scenario, the processing will not be proper. We might not be able to see the morphology properly, and most importantly, the receptor status may get altered. The antigenic sites may get hindered due to the protein linking that happens during fixations. So that is an important aspect that is to be known. And secondly, whenever there is a big resection specimen, it should always be taken into point that it should be completely dipped in formalin. Ideally, at least 10 times formalin should be there. The volume of the formalin should be 10 times as that of the specimen, but considering the MRM specimen, which are quite big, so it might not be possible to have that every time. But these specimens should be entirely dipped in formalin. And then our part comes in where we have to do or should do the grossing as per the proper protocols that have been established. What we follow in our institution related to the grossing and reporting is the CAP protocol, which is the College of American Pathologists protocol. So we are reporting everything according to that. HER2/neu We are reporting both IHC and FISH as per the ASCO guidelines. And for ER and PR reporting, we are using the Albert scoring system.
Thank you, Dr. Chanchal. I think you have really highlighted. That's what I tell to keep meeting your pathologists. You learn so many things. Simple things like how much of formalin should be used, what percentage. I'm sure 70 to 80% of the surgeons are not aware of these aspects, and which can actually impact the treatment of the patient. If you don't have an accurate report, that can totally change the treatment as well as the prognosis of the patient. So that is what I always tell. Keep interacting with the teams. It is not just the MDT, but it's a continuous interaction. Providing good quality information to the pathologist and imaging. I insist to show my residents what kind of a form you have filled for the pathologist. And Dr. Sandeep Mathur, our pathologist, just sends me a message immediately whenever there is a problem in the specimen. I get in the WhatsApp by evening, your core is very bad. So that is the kind of interactions we should try to develop to improve overall quality of. There's nothing personal in these interactions. It's improvement of the overall team. So we'll go to the next topic, the surgeon, Dr. Samir Gupta. Yeah, we have, I think, the role of surgeon is becoming more and more complex in the treatment planning. So coming to the surgical treatment options, what are the challenges you face when you see a patient of breast cancer in MDTs?
So the most daunting challenge that we face is when the patient says, "Ki sir, aap hi dekh lo jo karna hai." And that happens only in India, actually, right? When they leave everything onto you, then it becomes difficult, because as you alluded to, 20 years back, it was very simple. It was that same one road and that same one car which drove on that road, right? But still we try looking at the background of the patient, how educated they are, how much it will be possible for them to do a follow-up, the size of the tumor, how acceptable it is for them to undergo adjuvant radiotherapy, because for a breast conservation surgery, timely adjuvant radiation becomes very important. So I think other than the tumor related characteristics, it's the other socioeconomic parameters as well, which become important in deciding and communicating the treatment plan to the patient, which is quite unique to our setting. Unlike the West, where you strictly go by an NCCN or a ASCO guidelines, here it has to be guidelines, but they have to be discussed with the patient. And yes, if all the factors are favorable, T1, T2 disease, N1 disease, patient is reasonably understanding that it's not just the surgery, which is the pronged treatment, comprising a surgery, a chemotherapy, a radiotherapy, with or without a hormonal therapy. So all that has to be discussed right there in the first or the second meeting with the patient, and then we proceed accordingly, either on the mastectomy plan or a breast conservation treatment plan.
Thank you, Dr. Sami. I think you have really highlighted. You see, we also face similar situation at times. 50% of the patients are coming from rural background or educated. But what I have learned over a period of time, you should never underestimate the patient's intelligence or maturity. Even if they're coming from a rural background, if you give them some time to keep talking to them, they take fantastic decisions. So this we learn with over a period of time. And even uneducated, our breast conservation rates I have seen over last 20 years have gone up from maybe 5% when I joined as a resident. Now they're touching 60 to 70%. So I think it's a continuous effort, as you said, and we need to educate each other, keep interacting with the patients. We have our realities, but I think there is a lot of scope for change and improvement.
Definitely.
So I think we are another 5-10 minutes, maybe we'll just wind up. The next issue, I would like to come back to my medical oncologist, Dr. Isha. We have seen a lot of young breast cancer patients, ma'am, coming to breast cancer clinics and MDTs. Do you have any special concerns regarding these patients? Young breast cancer patients in the 30s, 30, 35. We see a lot of patients nowadays. It's a real challenge to handle these patients. So any special issues related to these patients?
In young breast cancer patients, we should discuss about the wishes of the patient regarding fertility. If the patient is unmarried, then we should always keep in mind that maybe in the future patient wishes to have a family. So ovarian function suppression is indicated even if the patient doesn't have a hormone receptor positive disease. So we should not forget that we should offer ideally in every young breast cancer patient ovarian function suppression. Why? Because even chemotherapy causes amenorrhea, chemotherapy causes ovarian function suppression as well, and because it damages the ovaries, so that can have long-term implications. So if we protect the ovaries by giving GnRH analogs beforehand, before starting chemotherapy, then the patient is safe from the fertility point of view. And as we all know that even in metastatic setting, because of the new medical oncology therapies available now, the survival has improved like anything. So we should never we should never lose hope, and we should never allow our patient to lose hope. And so all the psychosocial and the sexual issues should be freely discussed with the patient by the team. That's important. And then also for the bone health, yes, we should keep in mind that not only for those on having bone meds, we should offer zoledronic acid to even those patients who have any kind of fracture risk on the PMD scans, and especially the middle-aged women, they should be offered zoledronic acid. We can give it 6 monthly for those with any element of osteoporosis. So these are the things that we should keep in mind.
These are the special set of issues. That's what the MDT again will bring these issues into focus. If you are treating as a alone as a single physician, you cannot address all these issues. That's again shows the importance of MDT. Nowadays, when I see a patient of young breast cancer with a certain sort of family history or genetic background, it takes almost half an hour to 40 minutes for me to talk and decide the treatment plan. There are so many issues to address: fertility, family planning, risk reduction, reconstruction. So it is a very, very complex process. So we need to have a good team, and these are the special issues which can be discussed in detail in the MDT with medical oncologists like Dr. Isha. The fertility, we may have to include obstetrics and gynecology people if the patient is planning to have a family after chemotherapy. So there are a lot of issues because you cannot just start chemotherapy complete and start thinking about fertility later. It has to be done before. So the first 2-3 weeks are extremely critical for treatment planning. That's what I tell. I tell when the patient comes, she tells me, "Sir, please treat me quickly. There's some so-and-so doctor has told me that I have to undergo surgery tomorrow." So the question I tell them is, you want a quick treatment or a good treatment? So there is a difference between these two. The first 2 weeks you spend in the planning of a proper treatment will help the patient in a big way in the long term. So I think radiation we have discussed. We'll come to the challenges of multidisciplinary treatment approach. We'll go to Dr. Brinalni. So it is easier said than done that MDT should be done. But what are the challenges we commonly face? I think this is the last 1 or 2 issues I would like to discuss and before winding up the panel discussion. So in your experience,
Sir, my
it's a panel
yeah. Sir, my experience is not that long experience, but yes, definitely, as already highlighted, sir, I mean, like you have mentioned, the best treatment plan in toto, rather than like you are, I mean, surgeon is planning surgery and just ki abhi aapka problem hai, I'm just planning radiation, abhi aapka problem. It's not like that. I mean, just a total planning, holistic planning, and respect for each and every other modality. And just, sir, I mean, your cafeteria idea is very good. So, I mean, we can plan just in the cafeteria on the cup of tea. I mean, that's all. Just respectful for each other, sir. That's all.
Thank you. I think that's what I'm telling. The challenges is, I think we have different kinds of challenges. I'm not blaming anybody. We have different training backgrounds, different kind of setups. So we are learning continuously. We need to change. So the challenges include availability of expertise, what kind of people are available in your center, what resources we have, what guidelines you want to follow. Team coordination is very, very, very important. Some people may be short-tempered, some people may be egoistic. We need to balance everything. After all, we are human beings. So nobody is perfect, but we need to make a balance and try to bring the best out of everybody. Role definition is very important. Everybody should limit to their role. I should not talk too much about pathology, nor pathology should talk too much about surgery. So that's what it creates a confusion in MDTs. Communication should be very cordial and in a friendly manner. It is not a competition. It is not a question of superiority or inferiority or showing your expertise or knowledge. It is just sharing your knowledge and learning. And transition of care domains is very important. When you are handing over the patient to next specialty, you need to properly hand over the patient, tell them what are the issues. Suppose she develops a metastasis, I need to hand it the patient to the palliative care in a gentle manner, in a proper manner, rather than pushing the patient, go and meet the doctor. So these are the kind of things we should avoid when you manage in a comprehensive treatment planning and MDT setups. For the resources, now NCCN also now recommends, depending on the resource, you can plan your treatment guidelines. It's absolutely fine. You don't have to have the state-of-the-art linear accelerators and targeted therapies. If your resources have certain sort of facilities, you can prepare your guidelines and absolutely follow them. There is no shame in it. So these are the issues which everybody should understand. And who should manage the MDT? Again, it's a team job. It is not an individual job. What I would say is we should avoid using words like a leader of the MDT, in charge of the MDT. Then the problem starts. I would rather call a coordinator. Somebody can coordinate the MDT. Okay, so everybody is a equal stakeholder in that, or it can be a manager. So simple things like these can sometimes spoil the MDTs. So you have to keep all these dimensions in mind when you plan your MDTs. This is for youngsters when you start your teams in your new setups. So these are all may sound simple, but these are the big issues where many institutions cannot form good MDTs. So with that, I would like to end the panel discussion. We are just maybe 10 minutes overshot the duration. My take-home message is breast cancer treatments is complex and challenging. It should be managed by multidisciplinary treatment approach. It is not a one-man show anymore. If you are doing alone any treatment, you are not going to survive in future in the field of breast cancer. We need to develop common institutional protocols based on evidence, expertise, and resources. Keep all these three factors in mind. It need not be NCC guidelines all the time. Utilize common template-based structured clinical performance. Just create simple performance, start using them. Meticulous documentation is extremely important. If you take a decision, a joint decision in a cafeteria or while walking, I will come back and document that. This is what we have discussed, and this is the treatment decision we have taken, and this is the justification why we have taken that decision on that particular day. Try to maintain it. Initiate treatment with clear-cut treatment strategies and goals. Never start the treatment, then start thinking. You start the treatment, then you think after 2 weeks, what should we do for this? What should we do for the other aspect? So plan, then only execute the treatment. Shared decision making and patient-centric approach. That is the ultimate goal of the NBT. So with that, I would like to end this panel discussion, wonderful panel discussion. I wish I had more time to interact with all the wonderful panelists. I would like to thank all my panelists, and we hope to meet you all soon in an academic platform in future. Thank you very much.
Yes, thank you, sir. Thank you very much.
Thank you, Dr. Nal, Dr. Isha, Satyavati.
Thank you, sir. And thank you to all the panelists for the wonderful discussion. It was truly a very comprehensive discussion on the treatment master plan in breast cancer. I finally call upon Dr. Vaishali Zamre, who's the organizing chairperson, to conclude today's meeting.
Yeah.
Ma'am, over to you.
Yeah, thanks, Dr. Surabhi. What a wonderful start to this conference. When we began planning this conference, we had a lot of ideas in mind, but then we thought that probably we should divide these 3-day conference into learning the basics on day 1 and learning basically on the nitty-gritties of oncoplastic procedures on day 2, and then we'll be discussing about the special situations in breast cancer on day 3. And this day 1 actually has shown us that there is tomorrow is going to be a special treat for the budding as well as the oncoplastic surgeons. And I would like to thank all the speakers for sticking to the time, as well as for taking us through the all the various topics which we had requested you to talk on in a very comprehensive manner. I would also like to thank Dr. Ashwin for his valuable inputs after each talk, and Dr. Dev for moderating this session of panel discussion, and all the panelists. So before I say goodbye, I would like to request all of you to please join us tomorrow. And I'm sure, and I promise that it's going to be a wonderful evening. So please do join us at 6 p.m. Would also like to thank the team members of Mice Ideas for totally glitch-free and evening. We had a very, very wonderful evening today. So once again, thank you for joining us today, and have a very good night. Thank you.